So,
yes, sir. You can ask questions, sir. You can ask, sir.
are you able to see?
Yes, doctor. It is visible and audible, doctor. You can shoot questions, doctor.
Question is, what is the diagnosis? That's all.
No, we can't see. We can't see.
You can't see, sir.
We can't see. Dr. Koshy, can you see?
No. We are seeing only Jabir. Screen has not come.
Oh, sorry.
There is some problem.
Now I think your
Yeah.
screen has
Okay.
come. Okay.
Now it is visible, doctor. Doctors can start responding. Doctor, start responding, doctor. No one is responding now.
Coronary perforation.
No, you can write it.
No. You can please put it in the chat box. Put it in the chat box. Doctors, kindly respond in the chat box.
Please write it, put it in the chat box. You can take the chat box and write your answer and post. When the time is up, you tell me.
Doctor, 10 more seconds are there. Please respond. Yes, doctor, we can shoot another question, doctor. Second question. Doctors, kindly respond for the second question.
What is the diagnosis of this optical coherence tomography? One minute.
There will be overlap. So the corner views are good for visualizing.
Doctor, I can shoot next question, doctor. Time up. So time start for third question.
Naveen? Naveen, can I move and go to the last question?
Yes, doctor, you can proceed, doctor.
Yeah, this is the last question.
Yes, doctor, we can proceed next one, doctor. Time up.
Only 4 questions. I'll go to the answers. This is in fact a large coronary pseudoaneurysm. It is not a coronary perforation because it's a coronary perforation. You can see the dye goes up and it swirls around a circular structure with calcific margins. The coronary perforation, it's a contained perforation. In fact, if it is a coronary perforation, the dye will go out and it will stay there. Now you can see the contrast is going out. The contrast is going out and it is swirling around a circular structure with a calcific margin. And the second part, I think most of you have put it rightly. It's a covered stent being put and the pseudoaneurysm got covered. The optical coherence tomography, you can see here the stent struts and there is a big space between the struts and the vessel wall. And if you look down in the longitudinal view, you can see the red color. White color means it is well apposed. Red color means it is malapposed. More than 400 micron malapposition is considered to be significant. This is gross malapposition. The stent is actually floating inside the left main. You can see the left main is so huge. The left main may be 5 or 5.5 millimeter size. This is malapposition. This is a broad QRS regular tachycardia, right bundle branch block, left axis deviation. And not able to remove the point. You can see a fusion beat 1, 2, 3, 4, 5, 6. At the 6th beat, you can see it's a normal QRS pattern. It is not broad QRS and the axis is different. But the initial depolarization is the same as of the previous beat. And it seems to be a little early. So what is happening in the ventricular tachycardia is the ventricular tachycardia is going on from a focus in the ventricle. Same time, there is a contest by the sinus beat, which is also going. So at some times the sinus rate may go above the ventricular rate and it may capture the ventricle. So this is likely to be a capture beat, a hallmark of ventricular tachycardia. So right bundle, left axis, it is a left fascicular tachycardia. It's most likely a Wilson's tachycardia. Wilson's tachycardia usually a little more narrow, but this is broad. And if you look into the V3, you can see this may be a fusion beat even. And the procedure, this is a ductus being stented. Normally we close the ductus, sometimes we keep the ductus patent in any situations where it is a duct dependent circulation. This is a previous painting. Naveen? Naveen?
Yes, doctor. Yes, doctor.
So you correct the answers.
Dr.
Yes, doctor.
Jabir, I have one thing regarding that PDA standing. What about the R2SL? I don't know whether it is an overlap or there are only two SLs. Is it an overlap of the nominate artery and the left common carotid?
Which one, sir?
In the last PDA standing,
It was an overlap.
R2SL.
It was an overlap.
R2SL.
It was an overlap.
It was an overlap. Okay, fine.
Sir, you can go ahead with your presentation.
Okay. Can you see this?
Yes, sir.
I have to change the screen to okay. Okay, fine. This evaluation of is it moving? Is it moving?
Not yet, sir. Sir, could you go to the slide presentation mode?
Okay. Moving?
It is moving, but you are not in the slide presentation mode.
I think this is okay. All of you can see that.
We can see.
I think we'll go ahead because this has more clarity.
Okay.
Now, I hope this is okay. Evaluation of a prosthetic valve patients. I'll be touching certain points only because the time I cannot stretch it too much. So I think all of us can contribute. Now, this is a simple thing which all of you should know, There is a mechanical, biologic. Biologic could be stented, stentless, and percutaneous. These are the mechanical ones. These are the biological, stented one and non-stented one. And you have so many names. This is the percutaneous, expanded over a balloon and self-expanding. I think that doesn't require any discussion at postgraduate level. This also all of us should know that mechanical valves are extremely durable. The longevity is more compared to biological valves. Biological valves compared to the previous ones have better results or better longevity data now. The primary structural abnormalities, which I will be discussing later, are rare with mechanical valves. Wear and tear, calcification, all those things occur more with biological valves. And the malfunctions are secondary to perivalvular leak and thrombosis. And chronic anticoagulation is required in all. And with adequate anticoagulation rate of thrombosis is less than 2% per patient year. That is for bileaflet valves. Now we'll be discussing only bileaflet valves. And what is the approach to prosthetic valve patient? Most important is clinical information and clinical examination. I'll stress that the clinical information we have to take a proper history. What was the symptomatic or function class improvement after the procedure? How long the patient was symptom free? If the patient is becoming symptomatic, what are the symptoms suggestive of? Is it basically related to the valve disease? Valve? Is it related to other valve lesion? Is it unrelated to the valve disease? Something else? The complication prosthetic valve? All those things, rhythm, everything we have to look into. That is clinical examination. It's not only auscultation and echocardiogram. That's the most important thing, because if the patient is clinically stable without much symptoms, I think we need not bother very much. Then clinical examination, I will concentrate not on the routine cardiac evaluation. All of us should know systematic cardiac evaluation, but I will concentrate only on prosthetic valve. Then imaging of the valves with X-ray, fluoroscopy, 2D, 3D echocardiogram, transesophageal echocardiogram. Then cardiac CT has a role coming up, and catheterization is seldom needed unless we are thinking of something which is unrelated to this. And these are the auscultatory findings. I will not go into the details. Normal and abnormal. Normal cage wall process is seldom we put nowadays, but you may see a patient who had undergone this Starr-Edwards procedure about years back. There, the opening sound is purely metallic, or it is purely prosthetic valve generated. Whereas the closing sound is contributed by the prosthetic valve plus the native valve. So it will not be that loud and sharp. So the opening click will be louder and sharper in a cage wall processes. And invariably there will be an ejection systolic murmur, whether it is in the aortic or mitral process, because in the mitral process it will be projecting towards the LVOT. So it can produce problems. Diastolic murmurs are extremely uncommon. Disc valves. Disc valves, the opening click is very faint, may not be audible at all, and the closing click is the one which is audible in a disc valve, whether it is single disc like Pitra valve or Jock-Shelley or Medtronic valve. Jock-Shelley is not put nowadays, but you may have cases where it has been implanted years back. And bileaflet valve, and the common I think which is being used is a St. Jude bileaflet valves. In disc valves, the closing click will be louder, sharper. The opening click faint, may not be audible. In the aortic position, all the prosthetic valve will have ejection systolic murmurs because of the high velocity flow. Whereas in the mitral position, the disc valves do not produce systolic murmurs, may have a short MDM, very short MDM without pre-systolic components. That's the most important thing. If you get a mid-diastolic murmur over the mitral area in a prosthetic valve, see what is the pre-systole like. The functional or physiological MDM which is here in an otherwise normally functioning disc processes is confined to mid-diastole. And bioprocess is very impressive, but in the mitral position, they can have a short MDM. So that is simple. Most important is the click in disc processes, the closing click is well audible and opening click is faint. And in follow-up, most important is experience, the pitch of the click. The pitch gets dull and the sound becomes faint. This you may get from the patient, especially in Charlotte processes. It is very common. They can easily hear the closing and opening sounds. And one day they will come and say, I'm not hearing the sound. In this processes, the sound is not that great, so they may not be able to hear. But if they have heard the sound, they become tuned to that. And sometimes they may feel that the sound is not audible. You should be careful. And their noise also, sometimes an acute regurgitation, it may produce a noise which becomes, the patient may sense and tell that. Then phonocardiography, this is postgraduate, you should know. In a disc processes, in the aortic and mitral position, the sound to opening click, that is aortic to opening click, second sound to opening click in mitral position, and S1 to click in aortic position in disc processes is shorter than cage valve processes. This is the value you can note down. Now next is radiology. You should know the valve positions. You draw the midline, bisect the cardiac seal out in AP view or PA view, and 4 quadrants. Left inferior quadrant will be mitral obvious, right inferior will be tricuspid very obvious, left superior will be pulmonary very obvious, and aortic is almost at the crux. You can see that, you can see the valves there. Mitral, tricuspid, aortic, and pulmonary seldom seen. I don't think I have seen a prosthetic valve in the mitral position or in the pulmonary position. The lateral view is better. You draw a line from the carinal angle to the apex and bisect, horizontal bisect the cardiac seal out. Then again, the left and the left inferior, obviously this is the ventricle, so mitral. This is right ventricle, so it is tricuspid. Here it is the outflow tract, so it will be pulmonary, and somewhere near the crux will be the aortic. You can see that the 4 valves. And this is another thing which you should know when the X-ray step for your examination, because otherwise you have the data. The cage valve processes in the mitral position, it will be directed towards the apex, and in the aortic position, it will be directed towards the aorta. Okay. Then in the aortic position, it will be relatively small. So they will have only 3 struts, whereas in the mitral, it has 4 struts. This is the disc valve processes. This is one thing very clearly you can see the bileaflet prosthetic valve. There is a bileaflet prosthetic valve. Okay.
No, we are not able to see.
Okay, then I think I am helpless.
Sir,
Okay.
can you go to the slideshow? I think still you are in the
Slideshow, it is not possible. There is a problem.
Okay, that is fine, sir. But you are that one which you click now is not opening.
Okay, then that's fine. I don't think it will be seen in the slideshow. I don't know.
So can you show it
Okay,
separately in your?
Yeah, I think it will take some time because I am not an expert in this field. Okay, fine. Now that is a fluoroscopy I have shown. Now in the evaluation in fluoroscopy and things, what we are looking in is bileaflet. You are looking at the opening angle and the closing angle. This is the top is the fluoroscopic. I think it is visible to you. Is it visible?
No, no, it's not visible.
Okay, now is it visible?
No, now it has come.
Okay, I'll go ahead with these things. Now,
Sure.
this is the fluoroscopy where it is closed, the two discs are seen, and you take this angle between the two discs as the closing angle and opening this as the closing angle. So in fluoroscopy, a bileaflet, the closing angle should be more than 150 or 130, and opening angle should be less than 20 degrees. Then it should come and close very, very much. Whereas CT is now preferred to this thing. In CT, the approach is a little different. You draw the annulus plane, and these are two leaflets. Extend these things and measure. Can you see my pointer moving? Koshy, can
Yes,
you
it is visible, visible.
now you can see this is the angle. So it will be the opposite of that, because you take this and this is the tangent along the annulus. This is the leaflet which has been closed, and draw the tangent, and this angle is taken as the closing angle. And here it is open. This is taken as the opening angle. So it will be different. The opening angle in fluoroscopy will be less, whereas it will be more in the CT. So this you should know, because now CT is preferred over fluoroscopy, because a dynamic thing, it depends on at what level you are freezing these things, all those things. So CT is now preferred to measure these angles. CT is coming up in evaluation of prosthetic valves. After the fluoroscopy, you go for echo evaluation, type of valve and stability of the valve, calcification, abnormal echoes like pannus, thrombus, vegetations. You look for the flow pattern. Then you measure the effective orifice area, the gradients, look for regurgitations and quantify that. This is very important. Patient prosthetic mismatch you have to calculate and look for. Then basic anatomy, other lesions, ventricular function, all those things, just like any other cardiac case. Now, what are the abnormal echoes? Spontaneous echo contrast is seen normally in 7 to 50% of cases of varying extent, especially when you do TEE. The other is microbubbles or cavitation, strands, sutures may be seen. These things are very important. Then vegetations, thrombus, pannus. I will discuss a few of these things. This is the microbubbles. Okay, my video is missing. These are the microbubbles. You will see these bubbles rolling around in the cavity. And the first case I've seen years back, I thought it was grossly abnormal. I was looking what it was. And then one of my colleagues said that this is only gas bubbles. It is said to be due to carbon dioxide desagging. And these are the strands which are usually attached to the sewing ring and the annulus, seldom to the leaflet disc. It is along the annulus. These are linear filamentous strings which can extend up to 30 millimeters. But the anatomy is very important. It is linear, and serial echoes, it will be same. It doesn't grow in size. It doesn't decrease in size. It doesn't disappear. That's something which I want. Then I'll talk about pannus and thrombus. Vegetations, I think all of you know. I need not discuss about vegetation. This one common thing which is discussed, the pannus. Pannus is an ingrowth which occurs along the suture lines. Whereas thrombus, it can occur anywhere. It can in the annulus, it can occur in the struts, it can occur in the leaflets, it can occur elsewhere also. So suppose you are seeing multiple things elsewhere, you go for vegetations. Whereas if it is confined to the prosthetic valve, you have to try to differentiate. This occurs quite late, whereas this can occur at any time. Okay. Then location, pannus occurs more along the aortic valve because the annulus is relatively small and the velocity of flow is more, damage to the sewing ring tissues, that material, everything is more. So the pannus is more in the aortic valve compared to mitral valve, where thrombosis obviously in a larger valve, tricuspid more than mitral, more than aortic. These are small, relatively small, smooth along the suture line. It grows centrally, centripetal. It is more echogenic and it is immobile and it doesn't disappear. It doesn't digress, but it can grow slowly. Whereas thrombus, they are larger. You can get it any side. It project into the chamber or the great arteries. It is less echogenic. It has intrinsic mobility to some extent. And change in size. This is slow growth where it could be rapid growth or rapid reduction or disappearance because of embolization. Embolism doesn't occur, and the major problem with this is embolism. Then coming to the physiological parameters, velocities and gradients as usual, effective orifice area and the indexed effective orifice area, Doppler velocity index. These are all simple parameters which we have to go on doing. It becomes very simple. Then the pressure half time to see stenosis for AV valves and regurgitation parameters. Effective orifice area, this all of us know, but you are not employing it, so it may not be a familiar thing. The continuity equation, two sides, area into velocity is equal to area. If there is a continuous flow, this product will be same. So if you have three of these things, you can measure the fourth. So here we are going to measure V2, that is a prosthetic valve, and take the LV outflow tract. LV outflow tract, the blood flows through that without any hindrance. So cross-sectional area of the LVOT measured in the cross-sectional view. You can, in the cross-section view of the LVOT, you can measure, or in the parasternal axis view, you can measure it and use the parameter of pi d square or pi r square, and you can measure the area. And the LVOT cross-sectional area and the velocity time integral of the LVOT divided by the velocity time integral of the prosthetic valve. That will give you the effective orifice area of the prosthetic valve. Indexed to the body surface area, it will be indexed to the orifice area. The normal effective orifice area for St. Jude bileaflet, depending on the size of the leaflet which you are using, 1 to 3.2 centimeter square, and aortic it is 1 to 2 centimeter square. This is effective orifice area, not index. Now, Doppler velocity index is another method, because if it is going through an unobstructed thing, there will not be much problem. The velocities will be the same. The peak LVOT velocity, that is simple, or you can take the VTI divided by the peak prosthetic valve velocity. Okay, there can be some turbulence and this velocity can be more, so that the ratio will be less than 1. The velocity of the aortic prosthetic valve will ordinarily be more than the normal velocity. So you take the ratio of the peak LVOT velocity versus the peak aortic prosthetic valve velocity, it will be less than 1, but definitely more than 0.30. That is normal. In the mitral, it is the other way. You take the velocity time integral of the prosthetic valve divided by the velocity time integral of the LVOT. So as the obstruction to the prosthetic valve increases, this value goes up. So the value will become more. Normally, it should be on the lower side, less than 2.2. This is one thing which we are not discussing commonly. So the postgraduate should take a note of this. Now coming to prosthetic valve dysfunction. It could be structural abnormalities and non-structural abnormalities related to the prosthetic valve material. It could be strut fracture. The occluder may get fractured, or it may escape. Loss of leaflet mobility because something else. Ball variance in starved blood processes, that is lipid adsorption on the ball produces irregularities, nodules, all those things. Then sewing separation leading to dehiscence, calcification or tethering of bileaflets. These are structural abnormalities occurring in the valve apparatus. Unrelated to that, you have the pannus, which is tissue ingrowth, thrombus and vegetation leading to embolism. Endocarditis, all of us know. Stenosis, regurgitation are functional and non-structural. It could be structural also, but we are looking at the physiological parameters. Then the bleeding unrelated hemoptysis. And most important, we have to talk about patient prosthetic mismatch. Especially following a prosthetic valve implantation, early symptoms in a prosthetic valve, you have to look for that. You may find prominent murmurs, so you think the valve is abnormal. Here, the effective orifice of the normally functioning. So if you look at the valve is functioning normally. Okay, the valve is functioning normally. Whereas you are getting abnormal findings. That is, you take the valve area index. The valve area index should be on the higher side. It should be more than 0.85 centimeter square per meter square in the aortic and more than 1.2 in the mitral posture. That is the accepted prosthetic valve mismatch, patient prosthetic mismatch. this will not significantly interfere. And if it is less than 65, that is the effective orifice index is less than 0.65 in the aortic or less than 0.90 in the mitral, it indicates severe patient prosthetic mismatch. That means we have not assessed this issue considering the body mass index pre-operatively, which is very important. So in an obese person, you may put a normal sized valve. So here the importance is not only the annulus has to be indexed and the valve has to be indexed, a meticulous evaluation of the annulus and selection of the prosthetic valve size has to be a little more than the annulus diameter in obese people or when the body mass index is greater. There is a limit for that. So severe this mismatch occurring around 2 to 10%, and this leads to high gradients. The high gradients across a prosthetic valve could be due to malfunctioning prosthetic valve or a normally functioning intrinsic prosthetic valve. But the problem is because of prosthetic valve mismatch or because of other things like hyperdynamic circulation. The hyperdynamic circulation will enhance the gradient. Okay, so that is very important. When you get this prominent murmurs, look whether the patient has anemia due to hemolysis or endocarditis or fever or things like that. Okay. Then the other problem, what are the problems of this? The hemodynamics become worse unrelated to other things. Other parameters are stable, but the hemodynamics is unfavorable. Less regression of LVH in aortic valve disease and PAH in mitral valve disease. Obviously, the function class, quality of life will be poor. They develop more cardiac events, lesser survival, and faster degeneration in a bioprocesses. So it should be extremely careful in selecting the size of the valve. Now I'll take 2 slides on stenosis of the prosthetic valves because I don't have much time to discuss regurgitation and other things. That is relatively simple. Basic aspect in teaching is certain things we'll teach, the rest of the things you should read. Aortic valve processes, then normal, possible, and significant. So I'll take normal and significant. In between will be possible. So forget about this thing. Acceleration time less than 80 normal, more than 100 significant stenosis. Vmax here less than 3, more than 4, no problem. Mean gradient less than 20 here and more than 35, not more than 40. This is taken as significant in aortic. And more important is this is increase in gradient on follow-up. It is normally less than 10 millimeters mercury on follow-up at any time, even long term. Every annual you can't say because here it should be like that throughout its course. Whereas if it is more than 10, you should be careful. Increase. Suppose the gradient increases by more than 20 from the baseline data, that means the valve is becoming stenotic. And effective orifice area, not index, is less more than 1.1 centimeter square per meter square. That means it is normal. If it is less than 0.8, it is significant. Same thing, the Doppler velocity index, some people use the term dimensionless index. It is same. It should be more than 0.35 normally and less than 2.5 indicates significant as in the native aortic valve stenosis. This you can note down, it is important. And correspondingly in mitral processes, less than 130 per sharp time, more than 200. Vmax less than 1.9, more than 2.5. Mean gradient, that is what useful because less than 6, it is at optimal heart rate, not when the patient has fast rate. In AF, you have to take multiple values. A less than 6 gradients you can get in any valves and more than 10 significant stenosis. And on a follow-up, if the gradient increases by more than 5 millimeters, it is significant and effective orifice area is less than 1 centimeter square and diastolic velocity, Doppler velocity index more than 2.5. These are the parameters of mitral valve stenosis, prosthetic valve. So accelerate pressure half time more than 200, Vmax more than 2.5, mean gradient more than 10, and on follow-up if it is more than 5. These are the simple things we can do, which you are doing. Doppler velocity index more than 2.5. Simple things you get straight away within 1 minute or 2 minutes. Effective orifice area, some value, some machines have the value. Now, regurgitation, I may not take in detail how to quantify regurgitation, because even the simple native valve mitral regurgitation quantification, you are finding it difficult to recollect. So study that first. A little lower than that, that's all. But you should know that there is physiological regurgitation which can occur normally. And that is because when it closes, there will be a backflow. That is always there. And there is a leakage backflow which occurs a little after the closure. And this is relatively short, low velocity, narrow, asymmetric, and homogeneous, no aliasing. Pathologic, high velocity like this, intense, they're broad. You look at the difference, and aliasing occurs, which could be central or paravalvular. So that is about the regurgitation, to make sure whether it is physiological or pathological. And once it is pathological, you have to say whether it is a central due to the closure mechanism or paravalvular related to the annular suture, all those things. And once you have detected pathological regurgitation, you have to quantify that based on certain parameters which are little lower than the usual native valve regurgitation. I have not included it because too many things bombarded on you may not be very effective. So I tried to discuss. I have a video on this thing, but I think it will not be playing. I'll try again to get the other thing. It will take some time. So I think I may not attempt that. Physiological versus pathological, you should know. Once it is pathological, you have to see whether it is central, paravalvular, or even combined. Mitral valve, prosthetic valve stenosis, pressure uptime more than 200, Vmax more than 2.5, mean gradient more than 10. On follow-up, if the gradient increases by more than 5 and Doppler velocity index more than 2.5. On the aortic side, acceleration time more than 100, Vmax more than 4, mean gradient more than 35, and increase in gradient on follow-up by more than 20 millimeters of mercury, and Doppler velocity index less than 0.25. I think, and patient prosthetic valve mismatch, very important. In the mitral, it is less than 0.9 centimeter square per meter square. That is, the area index is less than 0.9 centimeter square per meter square. On the aortic side, less than 0.65. These values you just keep in mind. I think I've taken 20 minutes. It is not fair to discuss length. I think our faculty can contribute some areas which they think is important.
This is Dr. Dayasagar. Can I say something here? Hello, this is Dr. Dayasagar. Am I audible?
Well audible, sir.
Okay. I think Dr. Sudhayakumar made a good attempt to simplify the matters, but there's a new wall that is coming in, which is neither biological, neither it is mechanical. It is called a polymeric wall. There the leaflets are made up of synthetic polymers, and it is already being tried in India. It is 1 year data is already published in the Journal of JAC Interventions. No need for any anticoagulations with these polymeric walls. As of today, only surgically implantable aortic polymeric wall is being tried. The surgically implantable mitral polymeric wall is still in progress, and much more delayed than that will be the transcatheter polymeric wall. But be that as it may, just remember there's a new generation of prosthetic walls are in the offing. So just for the sake of updating, you need to remember polymeric walls as one that is going to come in the near future. The second thing is the differentiation between PANIS and clot. I think we often go only by the location of the imaging. Around the annulus, we tend to think more in terms of PANIS. But I think now there is one more objective method of differentiating the PANIS from the clot using the CT. The Hounsfield units, anything more than 140, it is supposed to be due to a pannus as compared to a clot, which is usually less than 40. So CT scan can differentiate whether the abnormal mass around the leaflets, is it a pannus or is it a thrombus? This is only one study. It is being considered now by many. Whenever you have what you call difficulties, or when you give a thrombolytic therapy and does not respond to it, probably you may think of doing a CT. One more clinical point about differentiation between a pannus and the clot is, if the obstruction has occurred for the first time 10 years after the surgery, it is more likely to be a pannus. If it occurs within the first 3 to 4 years, more likely to be a clot. This is purely a clinical judgment. There's nothing sacrosanctum about it. So basically now we need to remember that there is a new generation which does not require neither anticoagulants. Now, for that matter, they are telling now that the durability will be as good as the mechanical valves. So we have a new set of valves in the offing. That's all I can say about the prosthetic cardiac valves. Dr. Koshy, do you have any?
No, only just one point. See, when a patient with prosthetic valve is discharged from the hospital, the hemodynamics may not be very stable and all that. But when the patient comes for the first review, it is very important that we should very clearly mention that what exactly is the mean gradient, the peak gradient, what exactly is the heart rate and other parameters, even the DVI and all those. This will be very useful for follow-up. Many times what happened, we have no idea what was the gradient which was there at the time of implantation when the patient came for initial review. So that is a very, very important document. We call it something like the signature or whatever you call it. And that should be available with the patient. I think the surgeon won't do that. It is the job of the cardiologist working in the hospital. When the patient comes for the first review, document these things. Then you can easily detect a change which is happening to the velocity or the DVI or something like that. Second point, as sort of Sudhayakumar mentioned, though there are a lot of complicated things, one very easy thing is the DVI. Either you can look at the velocity or the VTI. All that you require on the aortic side is the LVOT VTI and the aortic VTI. So 0.3, whatever it is. That's the only thing which came. Otherwise, excellent and complete talk, like any other talk by Sudhayakumar sir.
And Sudhayakumar sir, sir, the murmur also, the quality of murmur in dry prosthetic valves, they can develop acute structural valve deterioration where the murmur may be a cooing murmur or a loud cooing murmur. That is one thing like what happens in a perforation, a valve perforation. Second thing is we may find it difficult, extremely difficult to diagnose prosthetic valve endocarditis sometimes where a positron emission tomography may be of use. Sir, you are muted.
The role of other investigations are coming up, as Sir said, the CT. That value of the HU is given in the ESC guidelines, but there is no large volume data to support that. But that is given to differentiate between that. And second thing is now MRI is also coming up. It is not a problem, MRI. MRI also helps to differentiate. The thrombus can be picked up by their MRI, certain methods, whereas the other thing can be differentiated. But these are all in the initial phase, and we need not go for all these things unless there is some real problem. I think majority of the problems can be sorted out by a meticulous clinical X-ray. X-ray may help in assessing the hemodynamics and other changes related to the valve. X-ray may not be that useful, but you can get an idea about the hemodynamics in X-ray, the pulmonary venous congestion, the anatomical remodeling occurring or reverse remodeling occurring in X-ray. That is useful. Never forget about X-ray. A standard X-ray should be there post implantation in a prosthetic valve as well as pacemaker. That's a must. We don't give too much significance because the change in the pulmonary hemodynamics, the reverse remodeling of the cardiac chambers, these things are very useful and follow the further remodeling. It is extremely useful. People seldom give importance to X-ray chest. Okay, that is second thing. And as we have said, positron emission tomography in selected situations, CT now coming up, MRI also is being discussed nowadays because it gives multiple informations about the thrombus, the pannus, the leak, everything it gives information. I think that's all. But basically what the postgraduate should know is what I have mentioned. I think that parameters, which are the important thing they have to look for. They have to look for that postgraduate level. They have to look for that, not only for examination. And as Dr. Koshy said, a meticulous evaluation of the cardiac chamber size and all those things. And more important, very simple things, I also feel valve area calculation is difficult. Gradient, you are doing it routinely. But DVI, that is a simple thing, especially on the aortic side, it is so simple. We need not go for the VTI, it's only the velocity, the pulse Doppler velocity of the LVOT and the aortic prosthetic valve. I think that's all. I think we had enough time on that, unless there are some questions from the students. What about Jabir?
Sir, I just wanted to ask you a question only. When can we do an MRI after a mechanical prosthetic valve?
Mechanical prosthetic valve, I think it is after 6 months. That is my impression. And bioprocess, it is after 3 months. That is my information. I am subject to correction.
And
I
we
think so.
can avoid a 3 Tesla MRI. We can.
Yeah. You should not go for a
Better
high-end
avoid.
stem. Yeah, that's a point. 1.5 up to 1.5. Am I right?
Yes,
I
yes.
think so. I think so. sir.
Yeah, 1.5 Tesla after 6 months.
Is
That's
safe. Dr.
Safe.
Jabir, one small point which everyone knows, but just wanted to tell. The common valve which we use, the TTK Chitra valve, the disc is not radio opaque.
Radio opaque.
So you cannot see it in the X-ray nor in the fluoroscope.
That's
Everyone
a-
knows that,
yeah.
but good to remember that. The PGs
But
should remember that.
very important, because that a question was asked last time, whether in star bits, what happens? Can you see the ball? Because it is elastic. It is faintly seen, in contrast to the bileaflet St. where you can see both the leaflets very clearly. Okay.
It's quite important question because some people may take the patient into the fluoroscope.
You cannot see that.
Under the fluoroscope, you are not able to make out anything.
But still fluoroscopy is useful because you can look at the stability of the valve. Whether the movement along with the cardiac cycle, whether it is something which is expected or whether it is having that abnormal rocking movement when it get discharged from the sewing ring in people with paravalvular leak and all that. Those things you can make out, but the disc you cannot really see.
Shall we go to the case presentation, sir?
Okay.
Thank you,
Sure.
sir. Thank you, sir, for your great presentation. It was quite useful. A simple parameters that we should keep. Most likely, it's always better to keep that chart in the echo room so that you can immediately look at the value.
That's why I concentrate on this chart, the hemodynamics. Regurgitation, I didn't go because it is a little more cumbersome. Because you have to know the native valve regurgitation itself, they find it difficult. You keep the chart. That is something like 20-25% less. That's all. The grading of MR. The regurgitant volume, the regurgitant fraction, everything is same. Even vena contractor is the same. Fine.
Okay, Dr. Manjuna, go ahead.
Good evening, all. Sir, let me share my screen.
Can you go to the slideshow, Manjunath? If it is not
Yes, sir.
possible, you leave it.
No, it's possible, sir. I shared it.
Okay, then do that.
Sir, is it visible?
It is visible. It is visible.
Thank you, sir. Sir,
Please go ahead.
Good evening, everybody. I am Dr. Manjuna, DM resident from Pushpagiri Institute of Medical Science. I am presenting a case of a 55-year-old female. She is a housewife hailing from Koyanjeri, Kerala. She studied up to 9th standard. She came with chief complaints of exertional palpitation since 30 years, breathing difficulty since 20 years, and swelling of both the legs since 3 years. History of presenting illness. Patient was apparently normal 30 years back, and she developed exertional palpitations, that is while climbing stairs, while hurrying on a level ground. These were of regular type, and it subsides on taking rest. This is not associated with any loss of consciousness or abnormal sweating or passing of urine. For these complaints, she consulted a doctor and she was told that she has a hole in her heart She was put on few medications and her symptoms got reduced. She also complains of breathing difficulty from the past 20 years, which is insidious onset, gradually progressive in nature. Initially, she had breathlessness while lifting objects, while climbing stairs. For a period of 1 year, it progressed to breathlessness while doing household activities in the kitchen. However, there is no breathlessness while lying down or no history suggestive of PND. For all these complaints, she consulted a cardiologist and was told that her symptoms were due to defect in her heart. She was advised to consult a higher center. She was advised to go to Sri Chitra, but because of her economical constraints, she was not keen on further treatment. She continued the same medications. She was taking on and off medications. She was in class 2 to 3 symptoms. From the past 3 years, she started complaining of, she also complains of swelling of lower limbs, more during the evening hours after standing for some long hours. Initially, it used to be up to the level of ankles. From the past 1 year, it is progressed up to the level of knee and mid thigh. There is no history of abdominal distension, facial puffiness, or decreased urine output. From the past 3 years, she also gives complaints of palpitations at rest, which are of sudden onset, irregular type, lasting for some 3 to 5 minutes. There is no history of chest pain. There is no history of syncope or near syncopal attacks. No history of joint pains, joint swellings, recurrent respiratory tract infections in the childhood. No history of claudication pain. No history of cough or hemoptysis. For all these complaints, she consulted a cardiologist who put her on medications, including a urine pill, and her symptoms got reduced. Presently, she restricted her activity to routine household work. Coming to the past history, her birth was a full-term normal vaginal delivery. At the age of 8 years, she had a fever and a respiratory tract infection. She had consulted a doctor and was told that she has a hole in her heart. And she was prescribed injection penicillin and she took it till the age of 23 years. I mean, till her age of 23 years. As far as she remembers, there is no cyanotic spells or squatting episodes. No history of recurrent respiratory tract infections in the childhood. She is a diabetic and hypertensive from the past 1 year on regular medication. Coming to the family history, all the family members are keeping good health. No history of similar complaints among the family members. She got married at the age of 23 years. She has 4 kids and all are healthy. All are of full-term normal vaginal delivery. There are no worsening of symptoms during their pregnancy. She attained menopause 4 years back. She takes a mixed diet. Sleep is not disturbed. Appetite is good. Bowel and bladder habits are regular. No other habits. I'm summarizing my history. She is 55-year-old female, hypertensive, diabetic, came with exertional regular palpitations from the past 30 years, from NYHA class 2 to class 3, insidious onset, gradually progressive dyspnea from the past 20 years, from NYHA class 2 to class 3, with pedal edema and irregular fast palpitations from the past 3 years, with history of hole in her heart and history of penicillin prophylaxis up to the age of 23. Sir, can I stop here? Can I go further, sir?
No. Let us have a little discussion and clarification and modifications. Shall I start, or Rao sir, you would like to?
You can start.
Okay, I will just give you some modification which you have to do. From here, avoid this hole in the heart. Don't use or translate what they say. She was diagnosed with a heart disease because there is a gross disparity. She was diagnosed with a hole in the heart and putting on penicillin prophylaxis. So avoid that. She was diagnosed with heart disease. That's all what is needed. Okay. The previous slide, can you go back? I'll make a little suggestions. The previous one, my friends, can you? Okay. Previous one. Okay, fine. That's okay. That's fine. Now this also you have to be careful because now she is 55 years. From whom did she get? From whom did you get this story?
Sir, I asked, like I kept on asking her.
No.
She told that her delivery was a normal delivery.
Okay, fine. I'm not questioning because it is extremely difficult because she studied only up to 9th standard. She is a housewife. So regarding at the age of 8 years, all those things to recollect, I am sure that you will not be able to recollect the events which occurred at the age of 20 years. That's a point. Can you recollect the headache which you had at the age of 20 years? No, it is not possible. So we need not go. You say that she cannot recollect the history of its infancy and childhood. And obviously no cyanotic spells. She cannot recollect cyanotic spells. So you can say, however, there is no gross this thing. And other thing, as I have said, the next previous one, the previous one. And now here, this should have gone along with the history of palpitation. That is your palpitation history. We should say that for the last 30 years, she was getting palpitation. Initially, it was on exertion and class 2. And over the last 3 years, she is getting palpitation at rest, which is irregular in type. No, don't say no history of passing urine. Say there is no polyuria during or after tachycardia. You use our medical terminologies, not what translating what they say. It need not be that elaborate also. Okay, you can be a little more precise. Avoid holding the heart. Then urine pill, you avoid that. Why did you use the term urine pill? I'm not say finding fault with you, but modifying. Why did you say urine pill?
After
She
taking
said-
that medication.
You said diuretic.
Yes.
That is what I want to tell you, that she was given drugs including diuretic. Okay, these are the comments about the presentation. I think we will go to the discussion after hearing from my co-teachers.
Yes.
At the end of the history,
Yes.
what is your what type of heart disease do you think she has?
Sir, she has an exertional palpitations. She has a breathing difficulty and also pedal edema. I would attribute to right-sided heart disease.
Hmm.
So I will think in terms of right-sided heart disease. And
Before
Right-sided
that,
heart
yeah.
disease, and then
Sir.
starting at a child that in a very, very young age of some heart disease at the age of 80 years.
yes, sir. So
What
I
is
would
the
think in
symptom
terms of
of
congenital heart disease.
right-sided heart disease? What is the symptom of right-sided heart disease?
They will have exertional palpitations,
No,
exertional.
see, you told the two important symptoms, exertional palpitation and exertional dyspnea. Those are the two important symptoms.
Yes, sir.
Now, there's also swelling of the feet.
Swelling of the feet is a right-sided heart complaint symptom of a right-sided heart disease.
No,
That is only for
because-
3 years.
Yeah, that's the point. It is after 27 years, she has gone in for right heart failure.
Yes, sir.
Yes,
The next thing, sir's question is, what do you think? First question, does she have heart disease?
yes, yeah.
Yes.
Yes, she
Is
has
it
a heart
con-
disease.
Is it congenital or acquired?
With the
That's the
history, it's looking like a
No,
congenital.
don't go into the day. Is it congenital or acquired?
Congenital, sir.
Is it cyanotic or acyanotic?
Acyanotic, sir.
So why don't you
Now,
say
why
this patient-
congenital? Why do
She
you think
was-
it is congenital?
She was told that there is a hole in her heart.
No, that is the point which Sudhayakumar sir was telling you, no?
Yes, sir.
You are telling that the patient was on benzathine prophylaxis, that patient had a long history of dyspnea on exertion.
Yes.
Why all on a sudden you are telling it congenital heart disease from the history?
No, at the age of 80
8
years,
years. She was.
at the age of 80 years, what other possible heart diseases are there? Apart from congenital.
We can have
Just a long history
there are
also. Yes, go ahead. Go ahead.
they can have conditions like primary pulmonary hypertension.
No, that's why I gave
Primary
you,
pulmonary hypertension.
I gave you a clue that a heart disease at 8 years, which has a long natural history of something like 50 years.
Went
That
on
also
for,
has to be kept in mind. What is the
Yeah.
commonest? If you take acquired heart disease, we think in terms of valvular heart disease, ischemic heart disease,
Still
hypertension.
rheumatic heart disease. I can keep rheumatic heart disease as the possibility.
which type of rheumatic heart disease? Stenotic lesion or regurgitant lesions or a mix?
I'll consider both, sir. As a priority, I'll keep stenotic heart disease as the first, and second will be regurgitant heart.
Now, why
rheumatic
is
heart.
stenotic heart disease as the first possibility in someone with palpitations and very, very long history of dyspnea on exertion?
Regurgitant lesions should be the first priority.
Yeah.
First one, yeah.
Yes, sir.
So
So he
regurgitant,
might have heard this. The cardiologist might have heard a systolic murmur. Somebody might have diagnosed as VSD. It could have been mitral regurgitation by another person, and that conflict might have forced the person to put him on rheumatic fever prophylaxis.
Yes, sir.
Okay, but
so
I
apart
feel
from
that-
congenital, and rheumatic, what are the other possibilities at the age of 80 years?
Uh,
Which went on for the next 45, 50 years.
any
He may not answer that.
any myocardial problems?
Which
Like?
myocardial problem?
Like RVEMF.
Okay.
RVEMF, out of
Going
all
on for
the
45 years.
RVEMF, what will be the symptom, predominant symptom in RVEMF?
Right-sided, right. I mean,
See,
right
Dr.
feet-
Manjunath, we are discussing gradually progressive dyspnea on exertion.
Exactly.
That is indicative of what? Is it a left heart symptom or a right heart symptom?
left heart.
Left
Dyspnea
heart
is a
symptom.
left heart symptom.
So you should think of conditions which can lead to gradually progressive dyspnea on exertion.
The disease
That is not the
progress-
symptom of, see, if you had told about LVEMF, we would have pardoned you, though it is not possible in this patient. At least, it is something which produces a left-sided symptom.
What is the myocardial disease which can remain minimally symptomatic for a long period?
Very long period.
Very long period.
Sir, hypertrophic cardiomyopathy.
HCM, they can remain asymptomatic for a long period.
Yes, sir.
Whereas the other cardiomyopathies, as Dr. Restrictive cardiomyopathies, dilated cardiomyopathies, they become more symptomatic.
Yes, sir.
Okay, hypertrophic cardiomyopathy can remain relatively asymptomatic for a long time, but
Yes, sir.
palpitation is not a very common symptom. Okay, fine.
Why do they develop dyspnea on exertion? People with HCM, why do they develop dyspnea on exertion?
So on exertion, peripheral vascular resistance will
No,
decrease.
no. You think, why do they develop dyspnea? Dyspnea is because of elevated left atrial pressure. That is what Dr. Koshy wants. And why do they have elevated left atrial pressure? Think of ventricular dysfunction. What type of dysfunction?
Diastolic.
Systolic.
Diastolic, because of diastolic dysfunction.
Yes. Now, is the question extended? Can it be HCM in this case? The thing
Sir,
is, natural
can.
history, once they go in for severe right heart failure, they will be in a very bad shape. They will not be in class 2 to 3 because seldom, I don't know whether I have seen cases with HCM who has gone in for right heart failure gross. I don't know what is the experience of others. Anyway, obviously, it should be very, very uncommon. Once they go in for right heart failure like this, they will be in a very bad shape. Am I right, Rao sir?
And along with that,
Yeah.
AF also.
Yeah,
AF also. Because you are telling atrial fibrillation, because towards the end, finally patient developed irregular palpitation, no?
Yes, sir. Irregular.
Unrelated to exertion, signifying that patient has developed AF.
Yeah.
So hypertrophic cardiomyopathy, AF, right heart failure, patient will be very, very sick.
Yes, sir.
As a matter of fact, the earlier the onset of the symptoms in HCM, the worse is the prognosis. The later the onset of symptoms, the better is the prognosis. So basically, out of all the cardiomyopathies, probably HCM has got a more benign course compared to restrictive cardiomyopathies and ARVs. But HCM patient presenting with at the age of 80 years and going on for the next 50 years, it's a bit unusual without having,
Unusual. Very
Yeah.
unusual.
very unusual. Any other possibility?
He may not answer. Sir.
Apart from congenital heart disease, sir.
Yes,
No,
sir.
we have finished
Heart disease,
congenital valvular heart
valvular
disease
heart disease.
and cardiomyopathy. What else?
I also
So-
find it difficult, sir, of 50 years natural history.
Yeah.
So can you contribute? Because they may not answer, sir.
Okay, any other congenital vascular anomalies that can present, that can go on for years? Coronary arterial.
Coronary cameral fistulas or coronary AV malformations.
Mhm.
Okay.
But mostly asymptomatic. If it is not a very huge shunt, very often the shunt is small.
Yes, sir.
Actually, that the disease was diagnosed by the doctor, but she was not that much symptomatic till she went through 4 pregnancies without having much problem. So it was more of a, what do you call, a doctor diagnosed disease rather than patient presenting with cardiac symptoms. The only symptom that was there was dyspnea on exertion. But then still she was able to carry on her regular household activities. So it's still possible, but sometimes we do
Okay,
see
I
some
think-
patients presenting with coronary cameral fistulas and even Al-Kappa for that matter. We have seen that. Very late presentations. Be that as it may. I think we'll go on to the
Okay.
clinical findings.
And before that, after the discussion, if you're asked to put 2 differential diagnoses, what will you put? And which is your priority?
Sir, I would like to, considering all the symptoms, I would like to put shunt lesion.
No,
Like
we have
AS
not gone to that level. Is it congenital? Which are the 2 broad groups you have said? Is it a congenital
heart disease.
aortic heart disease versus rheumatic heart disease? Which will you put? Could be either.
the history, and
Yeah, that's it.
I'll put congenital heart disease and rheumatic heart disease as the 2 options, sir.
Okay, if it is
Okay.
congenital, what is
Among
the
congenital
reason?
heart disease, which one?
Which one?
Sir,
That is it.
I would like to go for pre-tricuspid lesions, like I mean shunt lesions, like aortic ASD, atrial septal defect.
Okay. Can it be among the valvular lesions? One we have said is mitral regurgitation. Can it be aortic valve disease?
It
Or
can
combination?
it can be aortic wall disease, or aortic regurgitation, or aortic regurgitation.
Okay. Because it can be diagnosed. It can have a gradual progression over years.
Yes, sir.
Okay. But in the natural history, which do you think atrial fibrillation, in which group is more likely? You have atrial septal defect, you have mitral valve disease, you have aortic valve disease. Atrial fibrillation prefer you go for
Mitral valve.
Mitral wall
mitral valve
disease.
disease as well as ASD.
Yes.
ASD.
These are
Yes.
2 things. So to me, if I am given the history, I may think because it was diagnosed quite early based on clinical findings, I may go for a congenital cyanotic heart disease. ASD could go ahead because they can have mild exertional dyspnea. They have not PND orthopnea despite going in for right heart failure at the later phase and atrial fibrillation. I may put ASD as my first possibility. Second possibility, if it is a valvular heart disease, a mild mitral regurgitation due to mitral valve collapse or rheumatic, and gradual progression because MR can remain like that and they can develop AF. But mitral valve disease, when they develop AF, their left heart symptoms will be dominating. They may go in for class 4. They may be in more sick when they go in for right heart failure. So between the 2, there is mitral regurgitation or mitral valve disease going for the progression, AF, and severe right heart failure versus ASD. ASD will be relatively less dyspneic compared to left heart disease. So based on that, I may prefer congenital heart disease like ASD and other things. Can it be any other congenital heart disease which can present with palpitation and some degree of breathlessness? And Epstein is one thing you have to keep in mind. Epstein. So that is can present in any manner. So any heart disease you are entertaining, especially if it is congenital, Epstein should be kept lower in the list. I think that will keep maybe ahead of HCM, even though it is not classical, but Epstein can present in any way. Am I right, sir?
Yes, sir.
Exactly. Exactly.
There was you
Yeah.
consider the possibility of an LV and myocardial fibrosis as last in the list.
But I won't because
Age of
age
presentation
of
is
presentation,
too
lack
early.
of severe symptoms, and 30, 40 years progression with mild, relatively less severe left heart symptom, and despite going in for atrial fibrillation, I will think if I am entertaining mitral stenosis, I will keep LVM as the different diagnosis because they will
I
be more
also-
symptomatic.
I also think that among the various possibility, atrial septal defect, I would consider the first possibility.
First possibility. Yeah.
And the later development of atrial fibrillation. As a second possibility, rheumatic mitral with or without aortic regurgitation. Another point, ASD could be having MR. along with that.
Yes, sir.
We know that. That also is a possibility.
But basically, it is ASD.
Abstain, I may not consider very much because the palpitation, is an exceptional palpitation. It is not the re-entrant tachycardia or the AVRT which you get in abstain. She went through pregnancy without any problem and not a very common condition. So I think first two possibility will be ASD with or without MR, and second possibility will be rheumatic, mitral, with or without aortic. That will be my approach.
Yes, sir.
Okay, let's go to the physical
Okay,
finding.
fine.
General physical examination. She is a moderately built and well nourished, conscious, cooperative, well oriented to time, place, and person. Her BMI is 30. She is not dyslexia, no pallor, non-ectric. She has a pan distal clubbing of grade 3, and she has a central cyanosis. And saturation is as follows: upper limb, right upper limb it is 85, left upper limb it is 85, left lower limb it is 86, and left lower limb it is 88. Right lower limb it is 86. And respiratory rate is 14 per minute. She has a pitting type of pedal edema up around ankles, up to the level of ankles.
Can you just stop there?
Make,
Sir, can you just stop there?
Yes,
You
sir.
said central cyanosis is very prominent. And then you are giving the saturations as 85%, assuming that the hemoglobin is normal. Is it possible?
Keeping the hemoglobin normal and 85% saturation, it is very difficult to see the cyanosis, sir. If
Yeah.
hemoglobin is more. If
Is she a
hemoglobin-
very fair person?
Sir, she is a dark complexioned lady.
Then all the more difficult.
All the more difficult. 85 to have, central cyanosis is very deep is not really good. They don't go together. But pan-distal clubbing grade 3, probably yes. Okay, go ahead.
I have one point. I
Yeah.
don't expect a respiratory rate of 14 in this patient who is having ascites and cyanosis. Because ascites interferes.
No ascites.
No ascites.
No
No
ascites.
No,
But
sir.
even if the patient has cyanosis, with this stage, I expect a respiratory rate which is faster. There is cyanosis, so that will stimulate the respiratory center. Then this patient is not that stable. So I expect you should be careful because this is on the lower side respiratory rate. Females respiratory rate is faster than male. Okay. Next. Okay.
Coming to the CVS examination, extra precardial, pulse rate is
Don't go for that extra precordial, all those things. You need not go there. You just write a novel. Okay, pulse.
Pulse is 68 per minute, irregular, varying volume, normal character. All the peripheral pulses are felt, sir. No radioradial or no radiofemoral delay. Condition of the vessel wall is not thickened. Pulse apex deficit is 2, sir. And blood pressure in our right upper limb is 120 by 76 millimeters of mercury, and 110 by 70 in our left upper limb. And right lower limb systolic BP is 130 mm of mercury, sir. JVP is not elevated. Hepatojugular reflex is normal, sir.
See, even if the JVP is not elevated, you are supposed to tell about the waveform.
And especially when you find that the hepatojugular reflex is normal, because it is going up and coming down. The waveform is very important.
What do you
Normal
expect in a patient with atrial fibrillation?
Sir, atrial fibrillation, AV will not be seen. We will see V waves, X descent only, X dash will be seen, and Y will be seen, sir.
Do you ever see X descent so prominently in a patient who is in atrial fibrillation?
No, sir.
Y descent is sharp or shallow?
Y descent will be shallow, sir.
Why should it be shallow?
Why should it be shallow? Unless you say there is a severe RVH with non-compliant RV, Y descent should be rather steep. But in a patient who is JVP is not that much elevated, it is not easy. Finally, we have not written anything about response of JVP to respiration. You didn't think it is important?
It is important, sir. I examined her and even living.
No, but you didn't say anything there. In the examination, whatever you write is the final thing. So what you have not written is taken as you are not aware of it, or you are not aware of the importance of it.
So for
So what is
completion,
For completion's sake, you have to write.
so I have to mention like this: cervicular venous pressure is not elevated. Now there is a hepatojugular reflex which is normal, and I am also not sure when it is not elevated how to say whether the respiratory fall is there or not. I don't know. It is because it is not elevated, sir. I am not sure. If it is not elevated, we will not be able to say the normal inspiratory fall. You can say it is not paradoxical. Very unlikely that a normal JVP will have a paradoxical response. I don't know, but I fully agree with sir that it should be complete. Now there is a question which has been asked: how many waves will be there in the JVP when the patient develops AF?
If
Question is very clear. How many waves will be there in the JVP,
Yes, sir.
especially when you take the tracing when the patient develops AF?
So there will be X dash. There
No,
will be
how
V
many? How
no,
many?
no. Do you
How-
ever see X dash on the?
How many waves? 1,
Yeah.
2, 3, 4, none. Answer to the question. That is very important. Then explanation.
How many positive waves? How many negative waves? Let it put it simply.
See, there will be 4 waves.
No, there will be 2 waves. A wave has an ascent and a descent. Even though the question was put like that, there will be a wave has an ascent and a. What is that wave? When the A is taken away, what is the wave that is producing the X
Yeah.
descent? If you can answer that, I will give you a bonus mark. Anybody can answer that. You get the tracing. A is chopped off. X is chopped off, but X prime is there. So if there is a demand following the V wave, Y descent, the pressure rises. If you take a normal JVP and chop off that A wave, you find the Y descent, then the pressure rises, A is chopped off, you have the X prime. So there is a wave there, V wave. So what is that wave which you label? Okay, fine. It is H wave. Okay,
H wave.
H wave. Okay, go ahead. That is a distinction question. Okay, next.
So inspection and palpation, there is no precardial bulge. Apex beat is felt in the left 5th intercostal space on the midclavicular line. It is of weaving type.
1 minute. That in a child was diagnosed to have heart disease at the age of 8 years,
Yes, sir.
ending up with cyanosis. Patient was not cyanotic at that time anyway. Now you say there is no precardial bulge. What does that imply?
I mean, it was disease was not significant at the time of birth, or it was not that significant to produce the bony changes.
Bony changes.
In the sense, like before the ossification of costochondral junction, the disease may not be prominent, significant.
Might not have produced which chamber dilatations?
Right, RV dilatation.
Ventricular dilatation.
Yes.
Because he has written down the heaving type of the RV, pressure overloaded RV.
Yes, sir.
Now, can you put some oddities at this point? A patient who was having heart disease, which is progressive, developed atubation, has gone in for congestive heart failure. What do you expect the cardiac size to be?
Enlarged, sir.
Enlarged. Whatever lesion we have discussed, ASD, the RV should enlarge.
Yes,
If it is MRA, LV should enlarge.
yes,
So
sir.
you should check again. Second thing, I have some reservation about the heaving type of epic beat. The heaving type of epic beat, for practical purposes, we take it as LV hypertrophy. And when you say RV type, I don't think I have seen RV type of heaving epic beat. When does RV contribute or form the apex? What should happen to the RV to produce it, to occupy the apex?
It should
It should
dilate and
dilate. It should dilate. When it should dilate, either because of ventricular dysfunction or volume overload, it should be displaced.
displace.
Okay. You have
Yes,
said
sir.
there are no bony deformities, and usually it will not be heaving because it is a volume overload. That is my personal impression. Now, heaving, I use it for only severe aortic stenosis, severe hypertension, or LVOT obstruction. Okay. So that is
See,
the thing.
Manjunath,
No,
So
he
what
is
is the-
telling only
what-
parasternal heave. He is not
No, no.
mentioning.
Heaving
He is not
type. Apex
mentioning
is
about
heaving
heaving
type.
apex.
He said heaving type apex.
Yes, sir.
What is the description of heaving apex, Manjunath?
It is a sustained rise, sir, covering more than 1/3 of the systole.
2/3.
More than and
Not
it
more
will-
than 1/3. Heaving is more than 2/3.
more
No, no, how
Certainly
does
more
it-
than half.
Yeah.
more than half of the systole.
Certainly.
And it will be confined to the one intercostal space or 2.5 centimeter square area.
Then how is it diffuse? You
If it
cannot
is-
have a heaving apex and a diffuse one, and then you are telling it is RV type.
Okay, sir.
So don't go
You
for
are telling
conclusion.
parasternal heave separately. You are telling grade 3 parasternal heave. That we understand.
So
But
you
that
need not-
apex description is not conforming to the, the
not
classical.
compatible.
No,
Not
his
compatible.
interpretation of the precardial examination is not in the right direction because he's getting confused between RV and LV.
Sir,
Okay, go ahead.
You need not go into conclusions at this point. If
Yeah,
I am
yeah,
at your level, I will say
Yeah.
effect it is felt in the fifth left interval space in the mid-type line. It is diffuse and may RV type. Then
Yes, sir.
or I may not use that. Don't mix up the whole thing. That is what when you are writing, is it compatible? Is it congruous? These statements are congruous, and is it compatible with the clinical diagnosis and the other findings? If it is incompatible, you should check again. That's all. You may
Yes,
be
sir.
right in your findings. Okay, fine. Go ahead.
And the correct term is character. It is not type. The character of the apex, the location of the apex, the character of the apex. So whether you tell it is heaving or tapping or forceful, the correct terminology is character.
Shall I go,
Okay,
sir?
go
Shall I
ahead. Go ahead. Go ahead.
Parasternal pulsations are seen. Parasternal heave is present of grade 3, and there is palpable second sound in the second left intercostal space. There are no thrills.
You have to look
Is
for
there any-
pulsation
is
in
the
the second
second-
space. Sorry.
Yeah. Is there any pulsations in the second left interspace?
Sir, I was getting second sound pulsation, sir.
No.
Second
you
sound
answered-
pulsations? Second
Second sound
sound
was palpable. And
palpable,
no-
yes. Is the
Palpable.
pulmonary artery dilated or not dilated?
it is pulmonary artery is dilated, sir.
How did
See,
you come?
Manjunath,
Sir.
these two things are different. A palpable sound and pulsation. They are two different things.
Yeah. So whether only one is present or both are present?
Sir, I was able to feel palpable S2, but pulsations were not prominent. Only left lower left lower sternal border pulsations were prominent.
No, no. If
In
you
which
say,
space?
if you say
Which
second,
space?
Yes, yes. Sir, second
Third
space only
space?
S2 was palpable.
Where is the pulsation? Second space or third
And
space?
left second space, sir. Pulsations are in third and fourth left intercostal spaces. Third, fourth.
What is the structure in the third space producing pulsation?
Third space, it will be RVOT or else left atrium, sir.
Third space.
Left atrium.
Left atrium will be behind the RVOT.
No, no.
no, you're trying to say now, you have committed the diagnosis that it is a palpable S2.
Yes, sir.
What is the implication of that?
There is a loud second sound.
So what do you conclude of that?
It may be indicating pulmonary hypertension.
So
Yes.
you're telling it is pulmonary hypertension
Yes, sir.
without enlargement of the pulmonary artery.
Basically, once you finish the palpation
Yes, sir.
with the history, all the other things, you should have the anatomical and the hemodynamic data. Anatomical data is X-ray. What is the LV? What is the RV? What is the PA? What is the iota? You should get an idea. That's what we are debating. You have concluded that there is RV, but we are not mentioned about the PA. Regarding the hemodynamics and the rhythm, you have found that the patient is in equilibrium. His cardiac output seems to be okay because the pulse is everything is normal. And the P2 is or the second sound is loud. Usually it indicates it is pH, especially when the body mass index is 30, it indicates pH, whereas in a thin chest individual, it may not. Okay, what about the pulmonary venous pressure? What is the systemic venous pressure? These are the things which you have to have at the end of palpation and percussion. Auscultation is to refine these things. So if you look at the hemodynamics, you find the systemic venous pressure at present is normal.
Yes,
The
sir.
pulmonary venous pressure as per the symptom is not grossly elevated with all the limitations. Okay, the cardiac output seems to be okay because she doesn't have symptoms of low cardiac output. You said the pulse is of good volume and normal character,
Yes, sir.
and the rhythm is atrial fibrillation. So this much diagnosis is there. And on examination, you have found there is right ventricular dominance.
Yes, sir.
And there is palpable second sound in a patient whose body mass index is 30. So it usually indicates pH. You should look carefully for, because if you can get pulsations up to the third space in this lady, we expect dilated pulmonary artery. You might have not concentrated on that. Okay, so you should go back and look for pulsations. And third, when you say pulsation the third space, it is left atrium, the examiners may not be very happy. Okay. Even though you may defend that it is in that region, examiners may not be very happy. You need to say only the RV outflow tract. There are rare conditions, but RVOT. Okay.
Manjunath, can you expect third intercostal space, third left intercostal space pulsations in this patient?
Sir, I do expect, sir, since I have kept ASD as a diagnosis and
It's one situation, which is the other situation where you can get an RV output tract pulsation.
sir, Epstein's anomaly.
Okay. Then any other thing?
Yes, sir.
Pulmonary, any conditions with
You
pulmonary.
did mention about that today.
One myocardial disease you have said.
You did mention about
RVMF,
that.
RVMF.
Okay, yeah. RVMF, the entire precordium is silent except
Third
at the
intercostal
region
space.
of the third intercostal space, which is the only dynamic region. That is the infundibulum.
Same for the typical EM Epstein's also. In Epstein's also, the relative quiet precordium, the RVOT pulsation may be felt. Okay, fine. Auscultation, shall we go for the auscultation?
Sure.
Percussion, which area you will concentrate here?
Sir, I would like to look for the right border of the heart.
Yeah, that's right.
Second
Fine.
left
Okay.
intercostal space.
Okay, fine.
Percussion, left border of the heart dullness corresponds to the apex beat. Second left and right intercostal spaces are resonant. Sir.
So be
Right
careful.
border.
Be careful. We are not good in percussion. Okay. This is an extremely odd thing. Okay.
I
We
got
are
resonant.
going- No. First accept. Percussion, we are not good. Okay. We are not good in percussion. Number one thing. We complete that formalities for presentation. Okay. Accept that. Because you are going to make a gross error when you are trying to defend. You have a dilated pulmonary artery, a loud second zone without dilated pulmonary artery. It will be extremely difficult. So say, sir, so second space, I'm
Sir.
not sure, sir. Okay.
Sir, I tried looking for it again and again, but what I got, I just.
My
wrote
dear
it.
friend,
Yes.
you just go back, sir. I'm not sure about
I'm
the
not
second phase.
Yes.
Don't be adamant on saying that the second left intercostal phase is resonant. Don't be adamant. So that's
I
really
just
a
wanted
problem
to-
for you in the
No, no.
examination.
I just wanted to ask the candidate, what makes him to think that the second heart sound is really pulmonary component? Why can't it be an IoT component? After all, once you're thinking of a congenital heart disease,
Yes.
malpositions are quite not uncommon. So you are already made a conclusion that the patient has got pulmonary arterial hypertension. And then to add to your misery, you said pulmonary arterial hypertension without pulmonary artery enlargement. These are all difficult, statements which are not easy to justify your diagnosis. Anyway, go ahead with your auscultation and we'll see.
Sir, right border dullness extends.
Forget
one
about
side.
that. Forget about that percussion. We are not very much bothered about percussion. Okay,
Yeah.
right border, I agree. It is easy. Is it body mass index is 30.
Yes,
So
sir.
it's an obese patient. Okay.
Yes.
Even in a thin individual, I find it extremely difficult. So just to get away from that trouble, that's the best thing. Okay, rather than trying to say that you are percussed and found that. You say that the right border, left border, the second phase, I am not sure, sir. Fine, yeah, I accept it because I can't. Okay,
Yes, sir.
fine. But auscultation,
Coming to the auscultation, S1 is varying in intensity. Mostly it is normal, sir. And best audible at the mitral area. S2 is loud. The P2 component is loud. Best audible at the pulmonary area. And there is a wide and fixed split of the second sound. And there is no S3, there is no S4, no other sounds, and there are no clicks.
now you
What is your
will-
definition? What is your definition of wide split?
Sir, hearing a split both in inspiration and expiration.
And your definition of fixed split?
And the distance between the both the sounds A2 and P2 will be wide and equal in inspiration as well as expiration.
So now what is the implication? What is the implication of a split second heart sound in a patient who is cyanotic and club?
Sir, should I talk about condition?
Have you understood the question?
Sir, no, sir.
What can you rule out if you are able to hear both components of the second heart sound in a patient who is cyanotic and having severe clubbing?
Sir,
What conditions you can rule out straight away?
sir, any conditions with pulmonary stenosis
Like?
TOF? Any conditions with pulmonary stenosis?
Now, what is the implication of having two components of the second heart sound in congenital heart disease? That means there are two semilunar valves.
It's two semilunar valves. Yes, sir.
Can you think of a condition where there is only one semilunar valve?
Sir, truncus.
So you can rule it out.
Rule it out. Yes, sir.
Atresias, pulmonary atresia.
Sir?
Single second sound. Can you think of a condition where there is only one functioning valve? Fungus, pulmonary atresia, obviously.
Pulmonary atresia.
Yeah.
Aortic atresia.
The two components indicate that there are two functioning semilunar valves.
Semilunar valves.
And
Yes, sir.
flow through that valve.
And flow through that valve, functioning
Good
valve.
flow through that valve.
Yes, sir.
I have some reservation about your comments. S1 is varying in normal. Best audible at epic mitral area, you should not use that because you will get face questions. Why did you specify that? Second sound is loud. P2 best audible at pulmonary area. Obviously, it is best audible at the pulmonary area. So avoid such terms which are not needed. This is for your benefit in the examination. So
Yes,
S1 is varying in intensity normal. The mitral area, that best in the mitral area can be avoided. Second sound is loud, wide fixed split and loud. Then my question will be extending Rao sir's question. Do you know the phonocardiographic definition of wide split and wide fixed split? If you don't know, you should read that. It is not constant. The wide fixed split also phonocardiographically there is a variation in the split which is less than 15 milliseconds. Okay. And the expiratory split should be more than 30 milliseconds.
Yes, sir.
So that also you should know. It is not absolutely fixed. There is a variation. Okay. Murmurs.
Murmurs, I had one murmur, that is harsh blowing early diastolic murmur, which is heard in the second, third, and fourth left intercostal space, heard up to the mid of the diastole, and is not changing with the respiration.
No
What do
ejection
you
click.
think? So what do you think is the cause of early diastolic murmur?
Sir, it can be, by considering all these findings, it can be pulmonary regurgitation.
No ejection click, no?
No ejection click, sir.
Why it
Very
can't be
unusual,
aortic
no?
regurgitation? Why it can't be aortic regurgitation?
Sir, considering all the points starting from volume of the pulse and other findings in palpation like parasternal heave and all these things, I would like to go with the pulmonary regurgitation.
How many types of pulmonary regurgitation murmurs you are aware of?
Sir, 2.
What are they?
Sir, one is
Based on the pulmonary artery pressure.
based on the one is
I'm giving you
Increased
two.
flow. One is increased flow.
Increased flow,
Uh,
certainly not increased flow.
I gave you the flow, pulmonary artery pressure.
One is
hypertensive
hypertensive.
PR.
Other one?
Normotensive PR.
So you
And-
think this is normotensive PR or hypertensive PR?
With RVH and all. So
No. We are only talking about the murmur. So based on the murmur, what you have described, do you think this is hypertensive PR or a normotensive PR?
I will go with the hypertensive PR, sir.
Why?
Right?
Sir is asking about the timing. No, I'm
Any
giving you the flow.
difference?
Your internal examiner is struggling to help you.
Any difference between the two?
Sir, usually they will have a click. Hypertensive
No,
PR.
timing.
No. Click.
I
We are
gave
talking
you
about
the
murmur.
clue.
Murmur.
I gave you the
Talking about
clue,
murmur.
timing of that murmur
Timing of that murmur, peaking
in
and all
relation
that.
to second sound. I cannot give you further clues.
It will be
Early, immediate.
early peaking will be
Normotensive
early
PR,
PP.
No, not early
normotensive
peaking.
pulmonary regurgitation, where does it start? Is it early diastolic or late diastolic?
He is confused.
It's late diastolic.
No.
In normotensive PR, it will be late diastolic, sir.
It is
So
not
you
late
say that-
diastolic.
It is actually mid diastolic in time.
Okay.
Actually delayed, what they call delayed diastolic regurgitation.
You could.
Because there is a distinct gap
Yeah.
between the second heart sound and the onset of the murmur. Why that gap in normotensive PR?
Because of the one thing, pressure crossover.
Pressure
I'm not
crossover
sure.
means?
Normotensive PR, pulmonary artery pressure will not be high, sir. So diastolic pressure to crossover from the diastolic pressure, RV diastolic pressure, it takes some time.
Due to? What are the conditions where you get normotensive PR?
Sir, hypoplastic pulmonary valve.
Hypoplastic pulmonary
Not
valve.
a plastic.
Or absent pulmonary valve.
And
Absent pulmonary valve is a distinct entity, no?
yeah. And
There is
what is common?
What is the common? Have you
Why
heard?
disease?
Have you heard any patient having normotensive PR till date, or you have never heard?
He might not have heard. It could be idiopathic, the answer just like that.
No,
The
after
one common thing is a
post-intervention,
post-operative patient, post-operative
after post-
nephrology. That is a commonest condition which you find these days.
Even after balloon valvotomy of the pulmonary valve stenosis, you do hear sometimes. So actually the pulmonary artery will leak into the RV only after the RV diastolic pressure falls below the pulmonary artery diastolic pressure. So that takes some time. That is the reason. You go and read Perloff's chapter. It is given diagrammatically, and then he has explained to you why there is a delay. So if you say early diastolic murmur, it has to be a hypertensive PR, or it can rarely be due to an aortic regurgitation. Even in a cyanotic heart disease, for example, tetralogy of Fallot in adults, they can have EDM secondary to aortic regurgitation because aortic root dilates. Okay, so
my comments about this. One, you should describe like this, and early diastolic murmurs of pulmonary regurgitation are seldom harsh. So that harsh should be avoided. We may not be experts in assessing that, but they're usually not harsh. So you have to say there is a high pitch blowing early diastolic murmur. That is, if it is hypertensive, it starts with second sound. If it is normotensive, some terminologies, sir, there is a decrescendo, delayed early diastolic murmur. That is, some people use. Or a decrescendo, you have to say decrescendo murmur to convey that it is pulmonary regurgitation of normotensive type. Sir, there is a decrescendo diastolic murmur starting just after P2. Or some people use the term late or delayed early diastolic murmur. These are terms used. But decrescendo is the most important to say that it is a semilunar valve regurgitation. Okay. So as heart should be avoided. Okay. Up to the middle of diastole. No change with respiration. Okay. Fine. Any postural variation also you have to look into, because there is a difference between AR versus PR. These things will come into. And as Dr. Koshy said, there are no clicks. And seldom we hear EDM due to PH without clicks. And I expect a systolic murmur in this case, because significant pulmonary regurgitation in a dilated pulmonary artery, that too if you are entertaining ASD, usually there will be an ejection systolic murmur. Okay, fine.
Any other murmurs?
Sir, no other murmurs, sir.
Okay, go ahead.
Go ahead. Which are the murmurs you have to specifically say? Sir, no other murmurs like.
Like I was looking for ejection systolic murmur,
Okay,
as
fine.
well as and mid diastolic murmur at
Okay,
the
you have to tell that, because we anticipate certain.
Wait. Do you ever get
Mid-diastolic murmur, do you
mid-diastolic
expect?
murmur in a patient who is
Mid-diastolic.
cyanotic? Do you ever get a mid-diastolic murmur in the tricuspid area in a patient who is cyanotic?
No, sir.
Okay, what I
What
meant
is the
was,
murmur you get? What murmur you get in the tricuspid area in a patient like this?
Sir, we usually, sir, in a patient with cyanosis, will be right to left.
not that a patient who has gone in for right heart failure and atrial fibrillation with RV dilated.
Tricuspid regurgitation.
Pansystolic murmur of tricuspid regurgitation.
Okay, need
So
not be
three murmurs.
pansystolic.
Pulmonary regurgitation, an RVOT murmur, and a TR murmur. Those are the three murmurs you should look for.
Yes, sir.
What I was telling was, what I meant was to say that this patient is having no left right shunt. I may say that there is no tricuspid MDM. That I'm not expecting that, but I would like to say that there is no tricuspid MDM, there is no TR murmur, there is no RVOT murmur, there is no mitral murmur, because your final diagnosis ASD, and Dr. Koshy has said that they can have associated mitral regurgitation also. So these are the things, because in our differential diagnosis we had MR also as a differential diagnosis in our discussion. So all those things have to be kept in mind to exclude the conditions. Sir, this is only murmur. I've looked for an RVOT murmur. There is no TR murmur. There is no MR murmur. And I'm not expecting an mitral MDM in this tricuspid MDM. That is the way I present this case. Okay. Next slide.
What are your findings?
Yes.
Sir, other system examinations are normal, sir.
Wait. This is a congenital heart disease.
Yes, sir.
So what should you?
I look for the liver.
Only liver.
And I look for the liver, and I look for the to confirm the situs.
Oh, so you didn't say anything about that.
Sir, I commented here.
No. Even there you have not written down. Where is it?
Yes. Liver dullness is in the right.
No. So congenital heart disease, if we're suspecting it, at least in the abdomen, you have to say, what is the situs now?
Situs solitus.
What is the meaning of solitus?
If you don't know the answer straight away, say I'm not sure. If the question is unfair, not sir, try to. It is better say I'm not sure rather than making a mistake.
Solitus means usual.
Usual.
Means usual. How many types of situs you know of? Just tell them. Enumerate them.
Situs solitus, situs inversus, and mixed. I mean, mixed.
Huh? But you say the correct word. What is
The
the
answer
third?
is very ambiguous answer.
Situs ambiguous.
Situs ambiguous and meso.
And what did you say? You said something.
Situs solitus, situs inversus, and ambiguous. Situs ambiguous.
Yeah. So what is the Ive-Mark syndrome?
Sir,
Ive-Mark syndrome. IVEMARK. Ive-Mark syndrome. Have you heard of it?
No, sir.
Okay. Go ahead. Finish it off. Finish off. So what is your
diagnosis?
Yeah, what is your diagnosis?
Sir, I would go with, I like the situs solitus with livocardia, congenital heart disease, with cyanosis. So there is a right to left shunt or bidirectional shunt, Eisenmenger syndrome, probably
No,
ESD.
what makes you to say it's bidirectional?
Sir,
Why are you,
it is right.
what do you call telling things of which you do not have any basis for that?
Right to left shunt.
Yeah,
Right to left shunt with atrial septal defect, with severe PH, with signs of right heart failure, in atrial fibrillation, with no signs of infection.
wait. What is your evidence to say right heart failure here?
Sir, actually partially treated. She had
No.
a pedal edema.
You are supposed to say on the present status of the patient, not on what the history. You said right heart failure. Is it there or not there? What are the signs of right heart failure?
Sir, there will be a S3, RV S3.
Hey,
No.
right
There
heart
will be-
failure, very simple MBBS question. MBBS question.
So you have to
go
start
to the
from the-
MBBS level and answer. Right heart failure signs.
JVP,
Yeah.
pedal edema, JVP,
And in between, in the abdomen.
ascites, hepatomegaly.
No. Elevated jugular venous pressure, enlarged and tender liver, dependent edema.
Yes.
There are the 3 physical signs you have to tell. These have become more important because with the massive increase in the patient with heart failure, you need to have a fundamentals on your track. Otherwise, you'll get into difficulties.
See, this patient is a hypertensive. She could be taking amlodipine. That could be the reason for the lower limb edema alone. There's no
Yeah.
ascites, no JVP, nothing.
Yes.
No right ventricular third heart sound, nothing. So
Sir,
your point of right heart failure is very, very
Tenuous.
pedal edema
not a
started
very-
from the past 3 years, sir. Hypertension medication she started from the past 1 year.
That's okay. 1 year is enough to produce. Commonest cause for lower limb edema now is calcium channel
Drug.
blocker. You should accept that.
Yeah, drug induced.
Amlodipine is the commonest cause for lower limb edema.
So to avoid confusion and difficulties, you can put the diagnosis in simple terms without using very complex or controversial thing. Cytosolitis levocardia, congenital disease with cyanosis, right to left shunt. Obviously, cyanosis means right to left shunt. Sir, atrial septal defect with severe PH, Eisenmenger syndrome. No evidence of right heart failure now. Atrial fibrillation with controlled ventricular response, NYHA class 3. That will be enough. You go by the simple common types of presentation rather than mixing up the flow. Bidirectional we seldom use because it's not a clinical diagnosis, bidirectional shunt.
Yes,
You
sir.
can say left right shunt or right to left shunt.
What is your definition of pulmonary arterial hypertension? Hemodynamic definition.
Mean pulmonary artery pressure more than 20 millimeters of mercury,
20.
with pulmonary vascular resistance more than 3 Wood units.
Anything else?
This is for
No. Anything else? No. But there's one more important component.
at rest. This should be at the rest, sir.
No, that is removed already. There is one more. What about the cardiac output?
With cardiac output normal cardiac.
Totally wrong. Totally wrong. Normal or decreased. It cannot be a high cardiac output. Previously, it was the mean pressure of 25 as the definition for diagnosis. Now it has been changed to 20. What is the basis? What is the
Sir,
rationale?
mean pulmonary artery pressure, they kept it like 14 plus or minus 3.3. So, considering the highest level of 2 standard deviations, they reduced it to 20. Sir.
20, okay. Fine. Why did you say severe PAH? What is your definition of a severe PAH? In the examination, you better have to be very careful in writing these things because you're sticking out your neck to be gelatin. You just say PAH. Why do you want to say, what is your definition of severe PAH?
Does the EDM help? PR?
Or when does the
Essence of
EDM
EDM?
occur in pulmonary hypertension? Let me put it that way.
EDM occurs.
So these are
Not
all the
sure.
questions
You
that
say
you
not-
have asked for by writing that word severe PAH.
Now, in atrial septal defect, the pulmonary regurgitation need not be correlating with the degree, because Dr. Koshy was about to lead you to that statement. That is, what are the signs of severe PAH? One is in sinusitis, in the absence of any other thing, if there is a prominent A wave in the neck. Pulmonary hypertension with a pulmonary ejection click. Pulmonary hypertension with pulmonary regurgitation without disproportionate dilatation of the PA, right ventricular fourth sound. These are the clues for a severe PAH. A wave you don't have because it is atrial fibrillation. RVS4 you don't have. You don't have the click. So the only thing you have is the regurgitation. And in a patient with ASD, the regurgitation is contributed by the disproportionate dilatation of the pulmonary artery. So your pulmonary artery is dilated, P2 is loud in ASD without significant PAH. Because of the dilated pulmonary artery, the high flow, the P2 can be loud. So as sir said, you cannot say severe PAH, but you may be able to defend that because this patient with ASD which you have diagnosed has gone in for Eisenmenger. There is another evidence to say that the PAH has to be severe, but you should be able to discuss that. So as sir said, why do you want to use adjectives too much?
Yes.
You say right to left shunt, atrial septal effect with PAH, so situs solitus, levocardiac conditions, ASD with PAH with reversal of cyanosis, Eisenmenger syndrome. No evidence of right heart failure now, AF with controlled ventricular response. That is a simple method of putting the whole thing without controversy. Okay.
Yes, sir.
But I agree with you that we have been doing it regularly for so many years. So we may be able to put it in a better fashion than a postgraduate student. So don't get upset with that, because you cannot present the data the way we are presenting. Because we have been doing it regularly for years. Okay. But
Can we have the X-ray or ECG?
Yes, sir.
Which one would you like to have?
Sir, I will go with X-ray.
Why?
I want to look for the few signs, sir, like pulmonary artery, and I want to look for the right atrium. I want to look into the pulmonary plethora.
Will the chest X-ray help in confirming your diagnosis?
It will help, sir.
What way?
Sir, I would like to look for the RV type of apex, cardiomegaly RV, RV type. Pulmonary artery dilatation, I want to confirm. I want to see for right atrial dilatation, and I want to look for the signs of PAH.
I just want to know, which is the best view on chest X-ray, which definitely says there is RVH?
Sir, lateral view.
Then why are you insisting on PA view? Basically, you can at best you can say RV type or LV type. It is just not possible to say it is RVH and LVH just by looking at the PAV. This is exactly what I'm trying to say is, don't exceed the scientific limits of investigations. Go ahead, have the X-ray.
But that question I may answer like this. Sir, ECG, I'm expecting intubation, I'm expecting RVH, and secondary STT changes you are expecting at this age group. But the oddity in my case is, this patient I am diagnosing ASD with PH and Eisenmenger, but I could not see pulmonary artery pulsation, I could not see. So X-ray may help us to see whether my finding is right or wrong. That's otherwise, I don't think that with the diagnosis, with your clinical findings, one over the other may not be making much difference, but you have to answer that question. Now that question, I may prefer X-ray to make sure that the heart is enlarged, PAH, whether it is ASD or something else. So I'll get a definite idea about my diagnosis after X-ray. Because ECG, I expect AF with atrial fibrillation and RVH. So that is the way the consultants will answer, or teachers will answer, but not the students. It is a very difficult question. Seldom I ask this question nowadays, X-ray versus ECG, unless I'm sure that one is diagnostic. For example, a cyanotic heart disease, tetralogy of Fallot, ECG may be diagnostic for tricuspid atresia. If you are suspecting certain things, certain X-rays will be diagnostic. Okay, go ahead.
This is the X-ray.
Now with this X-ray,
Yes, sir.
do you expect the second left interspace to be resonant or dull?
Dull, sir.
But you said it is resonant.
Sir, I was not sure. Sorry.
You should have said that in the beginning. Okay, go ahead. What is your evidence to say there is pulmonary arterial hypertension on this X-ray? Radiological evidence.
Sir, there is a.
There's only one
pulmonary-
sign. You have to say that.
Sir, right pulmonary artery prominent.
Right pulmonary artery prominent. This is a very vague, you cannot say. Where do you measure the right pulmonary artery diameter?
So this.
No, that is not the way. You measure it in the right descending pulmonary artery after it has given the branch to the upper lobe. That's why it is called right descending pulmonary artery. How much it should be the size to say it is dilated?
Sir, I forgot. I don't.
You can say not sure. That's the best thing, rather than making mistake.
No. You just no. At least you should know the answer. The diameter of the right descending pulmonary artery.
Normal.
If it is bigger than the diameter of the trachea, then it is dilated. Absolute numbers are also there, but in this day and age of digital X-rays, it's going to be tough. So the RDPA is diameter is more than the diameter of the trachea, then it is RDPA is dilated. Can you have right descending pulmonary artery dilatation without PAH?
Or the question can be put like this: is it ASD with pH or without pH?
ASD with pH.
No. My question to you is, can you have right descending pulmonary artery dilatation without pulmonary arterial hypertension?
Yes, sir.
What is the cause? Oh, it is important to remember that, not just for the examination. What happens to the pulmonary arteries when there is absent pulmonary wall?
When there is absent pulmonary wall, there will be
Massive dilatation.
massive. Yes, sir.
Massive dilatation of both right pulmonary artery and left pulmonary artery.
Main pulmonary artery.
Okay, so
I may take the question back. Does this patient have pH? That was sir's first question.
yeah.
Does the patient have pH, and what is the evidence of pH? Because you are entertaining ASD. Without pH also you'll have the dilated pulmonary artery, dilated RPA, depending on the age and as well as the magnitude of the left right shunt. So in this case, what is the evidence to say that there is significant pH?
Some mean pulmonary artery is dilated.
That will be there in ASD without pH.
That will be there. Yes, sir.
Why do they develop pH?
Because
What
of
is
the
level?
increased flow into
That
the
is
pulmonary
flow
artery.
dependent, but when it is coming to severe pH, what is the reason or what is the mechanism for that severe pH? It is flow or resistance?
Mainly flow, sir, but
Resistance.
few trials
When
have
it comes to Eisenmenger syndrome, it is the resistance.
resistance.
Resistance is offered at what level of the pulmonary arterial system? At the main pulmonary artery, right pulmonary artery, or other area?
What type of pulmonary arterial hypertension is this? Type 1, type 2, type 3, type 4, type 5. Which one is it?
Sir, this is a pH.
Yes. Which type? You need to know this. Type 1 is where the pathology is in the arterioles. Type 2 is pathology is in the left heart.
Left hand.
Type 3 is pulmonary parenchymal disease.
So this is type 1.
Oh, you have to say that. That's why when the examiner asking you a straight question, you have to answer that. Otherwise, we have to assume that you are not aware of it.
So the resistance
four?
is offered at the
No.
pulmonary arteriolar level. So what will be
Yeah.
the radiological finding?
Now, based on this X-ray, can you say that
Yes,
the arterioles are constricted
Yes, sir.
based on this X-ray. Can you say it is constricted? Not constricted. Simple
Here
thing
it is not. It is
that
not
the outer
constricted.
one third
Is
does not show vascular markings. Whereas the central pulmonary arteries are dilated.
prominent. Peripheral pruning
Yeah.
Peripheral pruning means that is arterioles are constricted.
constricted. Yes, sir.
On the contrary, when there is pulmonary plethora, vascular markings go all the way to the periphery.
Peripheral.
So you need to look at the outer one third of the lung.
Yes, sir.
The gross disparity between the medial third and the lateral third.
Lateral.
The medial third is congested or opaque, filled with the greater pulmonary arteries, and the peripheral third is oligemic. That is the basic thing. So in between, the arterioles have constricted either because of reactive, obstructive, or obliterative changes. Okay, fine.
The chest X-ray is taken in the sitting position or standing position or supine position.
Sir, it was
Manjunath?
sir, a patient, it was taken in sitting position, sir.
Why?
Actually,
You think
that
is
was
a
a
good,
mistake. That
good
was a mistake
X-ray?
from our side, sir.
Pardon?
That was a mistake from our side, sir. That happened without our knowledge. And
No, just
No, no,
asking
when-
you.
no,
And
no,
it is
when you
written
take
that
a
it is
X-ray-
sitting.
No. Is it a PA view or a AP view? If you
sir,
take a sitting X-ray, you cannot be taking a PA view.
AP view, sir.
So you think this is AP view or PA view?
AP view, sir.
Why?
That's good. One
So
mistake.
that
okay.
can change the X-ray to a great extent, no?
Okay, we'll go to the, suppose if there is a left atrial enlargement in this patient,
Yes, sir.
what should you suspect?
I would suspect associated mitral wall disease,
Like,
like mitral stenosis or mitral regurgitation.
But do you expect a huge left atrial enlargement in a patient with associated ASD?
an income meeting organ and phone.
Because of the ASD, some part is like it is kind of second stenosis. So some part of it may not be. I mean,
No, it is
not
like
as-
second stenosis. No,
No,
what is
I
that?
know.
Let us be very
No,
clear
no,
about the
not second
basic
stenosis,
thing.
not second stenosis, sir. Like if like we cannot expect as we see in the proper isolated mitral wall disease.
See, the left atrium can always decompose into the right atrium. So only very, very seldom you get huge left atrial enlargement. You don't get. Even evidence of pulmonary venous hypertension will be missing.
Between mitral stenosis and mitral regurgitation ASD, MR can produce a better left atrial enlargement because there is a systolic expansion of the left atrium which get decompressed without rise in pressure. Whereas in mitral stenosis, the LA size is proportional to the rise in pressure also. You will not get a huge dilated pulmonary artery, dilated left atrium in mitral stenosis. So if there is mitral stenosis, the LA pressure rises, it can be easily decompressed. Whereas if there is MR, that systolic transmission can produce pulsatile expansion of the LA. So a relatively larger LA will be seen in MR in ASD. Got it? You have ASD. ASD with MS, LA will not be enlarged or only minimal enlargement. ASD with MR can have a larger LA, but as Dr. Koshy said, a aneurysmal LA, a very largely dilated LA is extremely, or it is
Unusual.
not seen. It is very not seen. Okay.
Can we go to the ECG?
This is the ECG of the patient, and ECG is showing atrial fibrillation.
Okay.
With controlled ventricular response, okay.
With controlled response. There is RSR pattern with STT changes in
But
V1.
go
V2.
ahead. Before that, axis is more useful in this case.
Yes, sir.
Okay.
Axis is axis is around 100 degrees
Mhm.
Minus 100?
plus 100. Sir.
Always use multiple of 15 or 30. Okay, roughly, because you say between 30 and 45 will be 30 and 60 will be 45 rather than saying plus 10 or plus 5. Multiples of 15 or 30 will be better for me. I will prefer that because exact is exact axis may not be easy. Okay, fine.
Is there a RVH or no RVH on this ECG?
There is no RVH according to the ECG, sir.
Wait. So what are your ECG criteria for RVH?
ECG
1, 2,
criteria.
3. Yeah, 1, 2, 3. In that order of importance.
Sir, in RSR, the second R should be more than
No, that is not the most important.
R by S ratio
R by S ratio.
should be more than 1.
But first thing first, more important than that, it is here on this ECG.
QR with STT changes.
No. So criteria for RVH is first thing is right axis deviation.
Right axis deviation. Yes.
Then comes your R by S ratio.
More importantly, is the S and
What are
VC.
the other causes of R by S ratio more than 1 other than RVH?
Sir,
Any electrical abnormalities?
sir, RBBB.
Okay.
RBB.
Any other problem which leads to arrhythmias?
Sir,
Pre-excitation
Yeah,
is
yeah,
time.
yeah.
WPW.
Okay. Anything other than that? You know, we have got a patient comes with chest pain and then you find R by S ratio in V1 is more than 1. So what should you suspect?
That you should answer. Acute
Huh?
MI.
Dextrocardia.
Dextrocardia?
Sorry, sir. Sir, chest pain, I would
Chest
suspect.
pain and then R by S ratio in V1 is more than 1.
With an upright T, with some ST depression in V1, V2.
Sir,
You know that. You know
coronary
that.
artery.
No, acute myocardial infarction.
Acute myocardial infarction.
What?
Type of acute myocardial infarction. What type?
Which area?
Sir, LMC or proximal LMC.
No.
Posterior MI. You
This
Sir,
is true.
ST
This
depression
is
posterior V1 V2 posterior wall MI.
Okay.
true posterior wall MI. Okay.
Your dextrocardia is also accepted because in dextrocardia you may get a good R wave in V1. Sometimes you are likely to get an R wave in V1 also. Okay.
Okay, let's go for the echo. It's getting late. 9:15 already. We are
9
almost.
o'clock we are supposed to.
Yeah, close. Go ahead. Plan it.
This is a
Give your
echo
ending
showing,
commentary, please. Give your ending commentary.
sir. This is the echo showing
Which view? Which view?
parasternal long axis. Parasternal long axis view. This is the parasternal long axis view showing left atrium, left ventricle, aorta, and RVOT. This is a picture showing parasternal short axis. Sorry, parasternal short axis view. Parasternal short axis view showing right ventricle. Sorry, left ventricle and right ventricle. There is a D-shaped septum, sir. Indicating.
Is that D? Is
there
it systole?
It's not D-shaped septum, D-shaped left ventricle.
a D-shaped left ventricle, sir. So,
Is it occurring during systole or diastole? There is an ECG down. Stop it. No, you just go back. Yeah. So where is that mark there?
sir, one sir.
Yeah.
The mark is in near the diastole, end of the near the diastole.
Where does the systole end by as per the ECG?
Systole ends by the end of the T wave, sir.
So where is it?
So, this is the T wave.
No,
T wave.
yeah. Where is the marker there? Marker is much
Marker
further.
is here, sir.
Yeah.
It's on the P wave. I mean, it's in the diastole.
It is the end of systole or early diastole. QT interval is called electromechanical systole.
Systole.
So end of systole. So if the ventricle is D-shaped at the end of systole, what is the implication?
RV pressure is high.
Higher than RA pressure?
RV pressure is higher than LV pressure.
So what was the LV pressure here?
110.
It was 110 by 110, around 110, sir.
Systolic. So this is RV pressure and LV pressure at least are equal, at least for a short while.
Yes, sir.
That
So-
parasternal long axis, can you show the cine? May not be a good frame.
Yeah.
I can't see the aorta anterior wall. What
Do
you're
we have
seeing-
any other views? Any other views?
Tricuspid-
we
you
have
are seeing
other
the
views.
tricuspid valve there. Okay, fine.
Okay.
This is the apical 4-chamber view.
Okay. What type of
Showing-
ASD is this?
Sir, this is ostium secondum ASD with a large.
The floor of the floor of the fossa ovalis is formed by which septum? Septum primum or septum secundum?
Floor of the interatrial septum.
No,
is
no, floor of
formed-
the fossa ovalis
floor of the fossa ovalis.
is formed by which septum?
Sir, septum secondum.
Totally wrong.
Septum primum goes. They both.
Okay, we will come back again. We'll come back. Yeah. So let's see all the views. Let's see all the views.
Now you should have more data to say what is the type of the ASD, the location of the ASD, is it single ASD or multiple ASDs. You should see the edges of the defect very clearly before saying that it is straightforward secondum ASD or it is a very large extension to the sinus venous step. Everything you have to look for. Single 4-chamber view is not enough. Okay.
And is this a single atrium?
Sir, there is a small septum near the lower end of the interatrial septum. Lower part. Unlikely to be single ASD, single atrium.
Single atrium.
Okay.
How do you suspect
Do
single
you
atrium?
have any other view
Yes, sir.
in which the IAS is seen better? Because this is,
Yeah.
difficult to.
Sir,
Okay.
this is the subcostal view
That looks better.
showing.
The second middle one is clear. Okay.
In which that measurement has been made. There, I think it is clear.
Yeah.
It is 4 centimeters. Sir.
Okay.
Okay. There it
4
looks like a
centimeters.
secondum.
Yeah.
Okay.
Okay.
And in the roof also there is part of the IAS and in the.
Now, what about the flow
Inferior
pattern?
part
There? You
also
could
there
not
is
get the
some
flow pattern. In the previous view, there was some flow. Can you go back to the previous one? The previous one, the color flow, can you show, no, previous one, where the color flow, can you run it?
Yes, sir.
Actually, the color is not very good.
Yeah, that could be systolic. Okay.
Hmm.
Okay, it is a TR which is going. Fine, go ahead. Next, go ahead.
That looks more like a TR.
You are
Difficult to
going
see
to the left.
any.
Yeah. Going to the left atrium.
This is the LV ejection fraction and
Okay,
TRZ. This is the TRZ, sir. It was difficult to get, and we got it 66. TR pressure gradient is 66.
Now, based on this TRZ, can you say the RV function is normal or depressed?
Or you
Are
know
we
the
based on
parameter.
this?
Based on the TRZ profile there,
Yes, sir.
can you say the RV function, RV systolic function is normal, depressed, or very good?
Sir, normal.
Based
What
on
is
what
your
parameter?
Say that. What is the basis for you to say that?
There is a good TRZ.
Good TRZ, that's not a criteria.
It is not good TR, that's something else.
What
Uh,
parameter, especially in the initial part of the spectrum?
What is dP by dt? Any idea?
It is the pressure, pressure difference in a time.
Well,
Or-
it is, no, it
Is it pressure difference or something else?
dP by
Rate of
dt.
rise of
rate of rise of
intraventricular
pressure.
pressure.
What you said is right. You have
Delta
you
P
should-
by delta T. That means change of pressure over change of time.
Yes, sir.
That is dP by dt. What is the normal dP by dt of the RV?
you say
Okay,
what
look
is
at
that?
the mode echo.
I don't know.
Mode echo and then tell me what do you see on the MOD echo? What is most obvious there?
RV free wall.
Sir, RV free wall is moving, sir.
RV free wall is moving, it is expected to move.
Sir, intraatrial septal motion is,
Wait.
Wait.
What the one is interatrial septum?
sir, interventricular.
So what is it? Is it normal motion or abnormal motion?
It's not normal motion, sir.
What is it like?
It's almost like a flat.
Not flat.
So what do you call that?
What is happening in diastole and in systole?
Is it, what is happening to the LV posterior wall in systole? It is moving anteriorly. What is happening to the interventricular septum during the systole of the left ventricle? Normally it should move towards it, right?
Yes, sir.
Here, what is happening?
Paradoxing.
Paradoxical septal motion. So what is the implication of that? What is the hemodynamic? What is the hemodynamic implication of a paradoxical septal motion in a patient with ASD?
pH and RV function is normal.
Wait. When does that happen, paradoxical septal motion?
It happens during the diastole.
No, paradoxical motion is occurring both here
And
is
diastole. It occurs
both
both in
systole and diastole. Usually it occurs, it's usually a sign of a RV volume overload. Okay. So what are the causes of RV volume overload?
Sorry, atrial septal effect,
Pre-tricuspid shunt.
tricuspid regurgitation.
Tricuspid regurgitation.
Any other regurgitation?
This patient also has the third one also.
ASD, yes, sir.
No, ASD you already said. Also has pulmonary regurgitation.
Pulmonary regurgitation.
So basically, so can you have RV volume overload without having paradoxic septal motion? Severe volume overloaded ventricle and not have paradoxic septal motion.
So RV dysfunction.
RV dysfunction, no. If I got a simultaneous LV volume overload, then you will not develop paradoxic septal motion.
Okay.
Classically, if it is an ASD with MR, then even though the left to right shunt is large, you may not have paradoxic septal motion. So there are some caveats in this interpretation. I think you need to put the clinical picture into the context before you draw conclusion. What is the normal thickness of the RV free wall?
Normal thickness is 5 mm, sir, around 5 mm.
Totally wrong. In this patient and the M mode, you think the RV free wall is normal, hypertrophic, or thinned out?
Sir, here it is looking hypertrophic.
Where do you measure? When do you measure the thickness of the ventricular wall?
In the diastole, sir.
Diastole. Okay. So
Yes,
in diastole, normally it will not exceed more than 4 millimeters. So what are the causes of thickened RV wall other than pulmonary wall problems, pulmonary hypertension and pulmonary stenosis?
Obviously, the problem should be in the
Myocardium.
okay.
Myocardium. Very good. Thinking is right. So what are the possible causes? Problems where there is problem with the RV free wall. Infiltrative disorders. Like?
Yes, sir.
Anderson Fabry
EMF.
disease.
Sir.
No, not
is
EMF.
not
Anderson-Fabry
infiltrative
disease.
disorder.
Anderson-Fabry disease. You can also get in hypertrophic cardiomyopathy.
Hypertrophic cardiomyopathy, storage disorders, Anderson-Fabry.
Yeah, so you need to remember that.
Yes, sir.
Okay. Let's
Here,
see.
biventricular volume overload. There are so many other conditions. Classically, it's hyperdynamic circulations. Biventricular volume overload occurs. Then the other shunt lesions where there is an intact pre-tricuspid shunt with intact IAS. You can have biventricular volume. Classically, it's RSOV, all those things. So those are the conditions where you can have biventricular. Okay. Then here
In
is
this patient, can you tell me what is the pulmonary arterial pressure?
Yeah.
Based on this echo. You must have done some more, no?
Oh, sir. Sir,
Can you estimate the pulmonary arterial pressure? Tell me what will
Pulmonary
be the arterial pressure in this patient based
sir,
on the.
it is 66 plus right atrial pressure.
That is systolic.
Systolic.
diastolic.
What about the diastolic?
You would like to have the next file?
Yes, sir. This is the showing pulmonary regurgitation.
So where do you calculate the pulmonary arterial mean pressure? I want to know the pulmonary artery mean pressure.
So this
because-
one from one, this gives the Vmax. From I'll multiply it by 4 into V square. That will give plus right atrial pressure will give mean pulmonary artery pressure.
No, you don't
End velocity.
You don't add right atrial pressure. You don't add right atrial pressure for mean pressure.
Sorry, sir.
Yeah. Okay. So what will be the what will be the right atrial pressure? What will be the pulmonary artery diastolic pressure in a patient who is having pulmonary regurgitation? And you say it is severe pulmonary regurgitation or by the clinical?
Yeah. It
How
is
do you
severe
calculate the
pulmonary
pul-
regurgitation, sir.
Yeah, how do you calculate the pulmonary regurgitation pressure or the pulmonary artery diastolic pressure based on this profile?
Okay, we have the values there on the
Yes,
next. You can look at the
Nine-
values and comments. What is the
Sir,
pulmonary artery systolic pressure? You have said 66 plus something like that, 75. What is the mean arterial
mean
pressure?
pulmonary artery pressure is 54.
55. And pulmonary
50
artery diastolic pressure?
Pressure is around 19.
When severe PR, there is a problem in giving significance to the PA diastolic pressure. The PA diastolic pressure, just like AR, will be lower. So here the PA pressure is mainly, we are concentrating on the mean arterial pressure. Okay. So here, don't give too much significance to that pulmonary artery diastolic pressure to quantify the level of pulmonary hypertension. That is a point. That is a point which I also want to convey. That the pressure in the pulmonary artery, you can have the systolic pressure, you can give significance to that it is severe. The pulmonary mean pressure, it is around 55, so it is severe PH. The pulmonary artery end-diastolic pressure will be lower, relatively lower. 19 plus 5 will be only 25.
Yes,
Okay, so that gives some idea. What is that? The pulmonary artery diastolic pressure is 25 mean. There is no significant post-capillary components.
yes,
That is, a pulmonary artery diastolic pressure is not significantly elevated, so there is no significant post-capillary component. Okay, fine. Shall we go to the next?
Yeah.
I think that's all.
That's all.
So what is your final diagnosis now?
Sir, the same thing. Cytosolitis livercardia with congenital heart disease, with Eisenmenger syndrome, with atrial septal defect, with PH, with right heart failure in AF.
Corrected right
No,
heart.
no. There is no right heart failure.
No right heart failure.
With
fine.
with no right heart failure and patient in atrial fibrillation.
Atrial fibrillation with
Controlled ventricular rate.
NYHA class 3.
What is your definition of class 3?
Sir, a marked limitation of physical activity. Marked limitation of physical activity, less than ordinary physical activity will produce symptoms.
No, yeah. Patient with
So-
heart disease. Having
with heart.
angina, palpitation, fatigue, or palpitation with a symptom on less than ordinary activities and marked restriction of his physical activity.
So how do you elicit that in the history?
Like routine activities will produce these symptoms.
Like what? No, routine or no.
Bathing.
Less than ordinary
Less
activities
than
you have
routine
said.
activity.
So what is less than ordinary physical activity, and how do you elicit that from the patient?
Bathing or walking within the house.
Now, that's why you need to have a structured questions. You need to ask whether about self-care activities. How do you quantify the degree of work?
Met.
Met. What is a met?
Oxygen consumption. Sir. Oxygen consumption.
No, what does met stand for?
Metabolic equivalent.
Equivalent. 1 met equals to how much?
3.7.
No, 3 point.
3.5.
3.7.
3.5 what?
ml per kg
ml
per
of
meter
what?
square.
ml of what?
Oxygen.
Oxygen.
Oxygen consumption less equal to 3.4. Some people say 3.6 ml per kilogram per minute.
Okay. It is not per meter square.
Per minute.
Per minute.
ml per kg per minute. That is a met. So when you are talking about self-care activities, with self-care activity has got a maximum mets of 3. You need to know, otherwise, you will have, how did you ask that less than ordinary activities? So you need to ask self-care activities, household activities, leisure activities, and sporting activities. Here are the 4 types of questions you have to ask. Then only you can say. If somebody is able to play shuttle singles without having any problem, he falls into sporting activities and class 1. And somebody is breathless in the bed and not able to comb or undress, or not able to take bath. Taking bath is 3 minutes of work.
3.
So you need to know what is the normal activities and how much of oxygen they consume. It's also important to know, what is the future of the patient's prognosis. Once you know what activities he can do or he cannot do, what you call functional limitations of these patients. In cardiology, the functional limitations, symptoms alone are the indications for intervention or whatever it is, surgical or non-surgical. Okay, I think we have far exceeded our time. Manjunath, you have done fairly well, but you need to improve your basic cardiac physiology and at least don't extend the importance of science beyond the limits of science.
Okay.
So whatever it says, you just say it straight and nothing more, nothing less. On the whole, you have done fairly well. I think there's still a lot of scope for improvement, both in presentation and in the content of your knowledge.
Okay, sir.
All the best for you.
Thank you, sir.
Okay, Manjunath.
Yes, sir.
I think my assessment about you, we have a reasonably good knowledge, theory knowledge about cardiology. And regarding the findings, we don't give too much significance because you already know the case and everything you might have discussed. But the problem is the presentation, history. We have to be a little more precise, comprehensive. Regarding the findings, you should make sure that there are no disparities. It should be congruous. If there is something which is odd, you should check again. And third, when a question is being asked, answer to the question rather than starting with the explanation for that answer. Okay. So if you are asked a question, how many, you say 2, then we'll ask whether what is the rather than going on and then coming to the answer, the exam may not be happy. Fourth, certain questions to me, to you will be very difficult. You should sense which are the questions which are difficult, you are not sure. There you don't try to explain or try to defend. You say, I'm not sure, sir, but not to all questions. Okay. So that's all. But overall, I think I'm impressed with your presentation. And as sir said, you have to modify your presentation, history writing, presentation, certain areas like that heaving effect within an RV enlargement, certain things, absence of resonance, the dullness over the second space. You should realize that percussion is extremely difficult for us. I'm sure that none of you are doing percussion in cardiology, that I'm sure. So we are not good in percussion. So there you should try to get away. Sorry, sir. To me, I was not sure. That is a way. Certain areas we are good, certain areas we are poor. That also you to realize. But overall, as sir said, we have done reasonably well. I think keep it up. Okay.
Thank you, sir.
Koshy has left.
No, I have not left. I have not left. I think he has done reasonably well. See, Manjunath, what is the spelling of Heisenberg?
Yes.
No. You should do it properly. Okay.
Okay.
And I think
One last question, candidate. Any idea who coined the word Eisenmenger syndrome?
Victor.
No, it is named after him. But who coined the word Eisenmenger syndrome? It's important.
Physician.
It's not. Okay, all of us are physicians only. It is Dr. Paul Wood.
have you heard of Cronian lectures?
Yeah, Paul Wood. Yeah, he has
Paul Wood
written down-
hypothesis. I read.
Paul Wood is
Have
the
you
one
seen
who
that
coined the
book?
word.
Have you seen the textbook by Paul Wood?
Oh, it is
At least you see
unlikely.
that. It's an excellent book.
Very unlikely. They are.
No, it is a very old edition.
And they,
I
I think
not-
1968 or something
Yeah.
like that.
Yeah.
Okay.
Okay.
So thank you so much, sir. I thank
Thank
all-
you. Thank you.
Thank you, Jabir. Thank you, Jabir, for giving
Thank
the
you.
opportunity.
Thank you. Good night.
Thank you, sir. Thank you, Koshy, for giving the company. I learned
Good night. Good
something
night.
from
Biggest thanks is to the presenter because it needs a lot of courage to present in front of these giant team.
Sure.
A lot of other students.
he was very confident. He was very confident. And some modification, that's all. Like that last question, who coined that term? If he is not sure, say that I am not sure.
No, overall, he has presented well. He is very
Overall, he has
confident.
presented very well.
He has presented well. Sure.
Okay.
But he can present better. We all of us can improve, no?
Okay.
Thank you.
Okay. Then.
Okay.
Fine.
Thanks. Good night.
Okay, Jabir,
Good
thank
night.
you.
Good
Thank
night.
you. Good night.
Okay, good night.
We should
Thank
have
you very much,
stopped
doctor.
early. Jabir, we
Oh.
should have curtailed because the participants number have come down from 45 to 23 in the last part. So I think time factor may be very important in the next session.
Next session, I think we'll conclude before 9:30.
Yeah, but that time because it was 45 to begin with, and it came down during the latter part of the discussion came down to 23. I was looking into that.
Actually, it raised up.
Doctor, actually it was 65, doctor. It was
Raised up to 60.
Yes, doctor.
I think because some of the PGs might have had duty or they may get.
Yeah.
Last only they start leaving, doctor.
All right. I think,
Yeah.
sir, next time we'll try to start by 7 o'clock and complete by 9 o'clock.
Complete by 9, at the most 9:15.
Okay.
You can have a check on us.
So what I'll do is I'll check the time and I'll inform you.
Yeah, you have to. You didn't do that today.
Today,
Because I was looking at that audience. It was coming down in the latter part. In the last 10 minutes, it was coming down.
Yes, doctor.
Okay.
but sir, a lot of things that the students should know, it was discussed. A lot of things were discussed.
Yeah, we have discussed to our happiness. Okay. Okay, but we have discussed so many things. If 25% of this could have been driven to the students, it's a great achievement. Okay. Okay, Jabir.
Thank you. Thank you, sir. Thank you.
Thank you so much, doctor. Thanks for
Jabir,
giving.
ഒരു പോയിന്റ് അവർക്ക് പറഞ്ഞേ എന്റെ ഇത് ഫോമർ പ്രൊഫസർ ഓഫ് കാർഡിയോളജി മെഡിക്കൽ കോളേജ് കാലിക്കറ്റ് എന്നാണ് മെഡിക്കൽ കോളേജസ് കോട്ടയം ആൻഡ് കാലിക്കറ്റ് എന്നാക്കിക്കോളൂ
Sir, note chedu, sir.
കോട്ടയം ആൻഡ് കാലിക്കറ്റ്.
Second thing is, Naveen, the winners of the quiz, you should send it across to the into the group.
Sure, doctor. Sure, doctor. I will send it, doctor.
Who was the winner today?
Sir,
Doctor.
four winners.
Yeah.
Dr. Grishma Sadashivan, Dr. Manjunath from Trichur Medical College, Dr. Das from Tirunelveli Medical College, Dr. Hariprasad from Lisie, and they answered all the 4 questions correctly. Then the 3 questions correctly, Dr. Remita and Dr. Vivek.
Okay, fine. Congrats to them.
Thank you, doctor.
Okay. See you. Good night.
Thank you, doctor. Good night. Have a nice day, doctor.